among the children to focus on the occult causes of poisoning, and we can discuss the general approach for poisoning. Toxic exposure occurs frequently in children throughout the world. The pattern of pediatric poisoning consists of international ingestion, mouthful ingestion, small amount, usually not more than 10 ml. In many occasions, the toxic agent is not identified. And in many, in the small, the history of the poisoning is not provided. So we'll go through the cases and remember obtaining an accurate history in intoxicated child or adult is challenging but still essential. The first case is 5 years old boy presented to emergency with department half an hour post ingestion of drain opener. He has mild cough post ingestion, but otherwise there is no other symptom, no vomiting or other respiratory symptoms. In physical examination, unremarkable. Oropharyngeal examination is normal, and systemic examination is normal. So in these cases, with normal oropharyngeal examination, systemic examination, most of physicians, they discharge the patient. So we'll talk about the household exposure. The household is the most common exposure among children, especially in the age group less than 3 years old, due to hand to mouth behavior, exploration behavior, availability of toxins, and hazard in the children environment in the house, lack of family awareness about the common serious medication and house hazard, and lack of children supervision. This study done in Riyadh in multi-center involving more than 1,000 patients. They found that the toxic household product having around 17% of all cases. Analgesic coming the second, 13%, especially paracetamol. And sodium hydroxide, sodium hypochlorite, which is the bleach, around 52 of the intoxications. So the household, the last year in 937, we have around 50,000 calls. Most of them is the household, reach around the 70% among the pediatric exposure. In annual report of American Association of Poison Control Center, they have around 2.1 million substances exposure in children less than 6 years, and roughly 25% of exposure were to the household cleaning substances and personal product. And 62% of caustic ingestion occur in children less than 1 year, and the clinical manifestation of caustic ingestion do not predict presence or severity of esophageal lesion in the children, like our patient. So when we consider this is causative or corrosive, um, we have either acid or alkali. The acid with pH less than 3, alkali with pH less than 11.5, like sodium hydroxide, potassium hydroxide. The mechanism of injury in the acid is coagulative necrosis, and alkali is liquefaction necrosis. Um, Alkali is low viscosity going through the esophageal and causing esophageal injury. The risk of stricture is more. In the acid, the stomach injury is more because of pouring of acid in the stomach and because of pyloric spasm. And that's why they are risk more for aspiration. The severity of injury depends on the nature of corrosive, pH, amount of the substances, and the purpose. For suicidal, associated with large amount ingestion and more severity. This is 10 years old, 10 years period study evaluating all patients with corrosive ingestion. All children underwent upper GI endoscopy within 24 hours. Total of patient 156, and 61 show there is no signs of injury. By endoscopy, they found around 37.5 percentage of patient have the endoscopy evidence of bear. The predictors, the best predictor for severity, if positive, of morbidity and mortality is the extended of injury as assessed during initial presentation. So positive finding associated with more severe. Stridor is 100% specific for significant esophageal injury as well. The acute complications, either upper airway obstructions, aspiration, GI bleeding, perforation, and choke. The chronic, it's mainly esophageal strictures, pyloric obstruction, gastric outlet, and squamous cell cancer, which is around 1,000 times more in those child. This is the endoscopy. We have the normal esophagus. This is first degree associated with only erythema. The second degree, either near circumferential or full. Grade 2 and grade 3. The grade 3 is associated with necrotic tissue. Grade 2B and 3 associated with structure formations, around 100%. So structures occur around 3 to 10 after ingestion with documented esophageal burn. Occur in all patients with severe circumferential burn, grade 2B and grade 3. The endoscopy is recommended for all symptomatic patient, any patient with oral pain, bloody vomiting, stridor, drooling as well, and any patient known to ingest substances with high risk of esophageal strictures, like sodium hydroxide and potassium hydroxide, and also um, the acid like phosphoric acid and sulfuric acid, and should request for all patients with suicidal attempt, usually done in initially 12 hours to 24-hour post ingestion. We, we, we don't like to do it before 12 because of limitation of the study because of edema. And after that, especially between 3 days and 2 weeks, there is thinning of esophagus and associated with risk of perforations. This is the most common household uh, hazard in the house. Uh, is sodium hypochlorite, bleach. Usually the concentration is less than 5 or around 5%. However, the pH is 11.4, but still it's not corrosive because of low concentration. Um, the, the most risk is the aspiration. So if there is vomiting or cough, this patient need to be observed in emergency, otherwise can be observed at home. They find in many study, there is no structure formations risk for the bleach. This is the most dangerous, sodium and potassium hydroxide. Sodium hydroxide used in the drain opener, and potassium hydroxide used for the oven and in general cleaning of oils. Toilet cleaner, like the most famous is Flash, which is hydrochloric acid and also phosphoric acid associated with risk of uh, uh, stomach injury as well. This is the how to manage the patient and the approach for household. In general, if not uh, potentially risk for perforation or for esophageal injury like sodium hydroxide or potassium hydroxide, sulfuric or hydrochloric acid, this patient can be observed in emergency department for around 6 hours. If patient is symptomatic from beginning, should be admitted and consider endoscopy. And in patient with airway compromise, should be initially stabilized, secure airway, and then consider endoscopy after 12 to 24 hours. We have another case, 9-month-old presented to emergency department with history of fever, 3 days, started vomiting. Today he has vomiting 4 times and physical examination annual and lethargic. Indecently, they found that liver function test is very high. ST is 1,700, LT is 1,500. Back to the history, the child is 10 kg. He ingests around 180 milligram per kg per day for 3 days. Coagulation profile as well is prolonged, and paracetamol level is high. So we are talking about repeated supratherapeutic ingestion overdose. We consider the overdose if more than 150 milligram per kg per day for 24 hours, or more than 100 milligram per kg per day for 48 hours, or more than 75 milligram per kg per day for more than 48 hours. The risk factors: malnutrition status and underlying liver disease associated with low glutathione store, and cytochrome B450 inducer like carbamazepine and INH. This study about repeated supratherapeutic overdose, they find liver injury secondary to repeated dosing of paracetamol should be considered when a child has received more than 75 milligram per kg per day for 2 days. And actually, those patients usually presented late, and prognosis is bad. The role of the normogram for those patients is not there, so we cannot use the normogram. And also for incorrect timing of history, multiple ingestion, like this patient, or chronic use of paracetamol. A factor that increase risk of toxicity and altered toxicokinetic, like anticholinergic, antihistamine, and opioid, due to delay gastric emptying. Ingesting more than 24 hours before presentation as well is not applicable here. And management of supratherapeutic overdose usually will measure the paracetamol level, INR, and uh, liver function. If either one of elevated, treated with N-acetylcysteine for 21 hours, and then we'll repeat again the paracetamol level, INR, and LFTs. If any one of them still high, we'll continue another 16 hours. But if undetectable paracetamol, INR normal, or liver function is normal, so no need for treatment. Case number 3, this is 2 years old with URTI symptom, presented to emergency 2 days before, and discharged on common cold medications. Today he is presented with a decreased level of consciousness. Physical examination, he is bradycardic, bradypneic, hypotensive, plus coma scale is 11, 10 to 11, and pinpoint. This is the real case, I saw it. Other systemic manifestation is normal. So if we go through differential diagnosis, we consider sepsis is number 1. But when we go back to the history, this patient was discharged with amidazoline nasal decongested. And actually, this patient ingested the amidazoline. The other differential diagnosis, opioid and sedative, calcium channel blocker, beta blocker, digoxin. And we have another patient with same presentation, is dafla or difla. I don't know in Arabic actually, but it is Olender. This patient, the other patient presented to emergency department with ingestion of the seeds. It's like digoxin, and it's more dangerous than digoxin, by the way. So this is alpha agonists associated with decrease of the sympathetic outflow and increase of parasympathetic outflow, which is the result on the bradycardia and hypotension, and centrally cause the coma, decreased level of consciousness. So management always ABC, maintaining airway, IV fluid boluses for the hypotension, epinephrine and dopamine, atropine for the bradycardia, and naloxone, especially for pediatric age group. In literature, the literature reports the response to naloxone reach around 20 to 25% of patients, and especially in the pediatric age group if given early of presentations. And pediatric age group, they found that patients have hypertension after giving naloxone. So drug and toxin-induced ECG abnormality. When to consider ECG for all suicidal ingestion and unknown ingestion, medication like antipsychotic, antidepressant, cardiac medication, and hypertensive medications, and antihistamine also as well. Bradycardia usually we see with beta blocker, calcium channel blocker, cardiac glycoside like digoxin, alpha adrenergic agonist like our patient, and cholinergic, tachycardia, we found in sympathomimetic, anticholinergic thyroid hormones, especially with large doses, usually more than 3 milligram. And the tablet always is 50 to 100 microgram. Salbutamol ingestion, carbon monoxide exposure, ventricular tachycardia, we found in sympathomimetic, antidepressant, antipsychotic, and ingestion of potassium, prolongation of QRS and QTC, we find mainly in antipsychotic and antidepressant, antiarrhythmia also, ondansetron also, and lithium. The fourth case today is 6-year-old boy presented to pediatric emergency department with vomiting and diarrhea for 2 days, lethargy and cyanosis for few hours. This patient is coming to the emergency department after that, dusky color, tachycardic and tachypneic. His saturation is around 77 to 83, despite administration of 100 oxygen. When blood taken, it was dark chocolate color appearance. So this is consists with methemoglobinemia. When we back to the history, this patient given by herbal medications. They are mixing gunpowder in the water with some other herbal and given for GE to stop vomiting. So the gunpowder is the content is nitrates, and this patient presented with methemoglobinemia level, which was 47%. After single dose of methylene blue improving of cyanosis and oxygenation as well. So please consider methemoglobinemia. And the last year I received around 12 cases. In Qasim also, in Bisha, many cases. The fifth case today is 2-day-old boy presented to emergency department with history of uncontrolled excessive crying, fever, diarrhea for the last 36 hours. The physical examination, he was irritable, febrile, tachycardic, and tachypneic, and he looks small for gestational age with no dysmorphic features. So 2-day-old with fever, irritability, we consider CNS infection number 1 and sepsis. But when we go deep in the history, we find the mother, she was addict. So this is neonatal abstinence syndrome. NAS is a clinical diagnosis result from an abrupt discontinuation of chronic fetal exposure to substances that were used or abused by mother during pregnancy. It's generalized multisystemic disorder involve CNS, and this is the first science always, autonomic nervous system and gastrointestinal tract as well, diarrhea, vomiting. Between 2000 and 2009, maternal opioid increased from 1.2 to 5.6 million per 1,000 live birth in US, which is significant number, very significant. The Committee on Substances Abuse of the American Academy of Pediatric, they recommend comprehensive medical and physiological history, including specific information related to maternal and drug use, part of every newborn evaluations. So the maternal factors, the history of substances abuse, inadequate antenatal care, perinatal infections, previous unexplained intrauterine fetal death, and previous baby with neonatal abstinence syndrome, placenta abruption, abruption as well. The neonatal factors, low birth weight, intrauterine growth retardation, unexplained prematurity. Clinical presentation, first sign usually the same as irritability, jitteriness, tremor, excessive crying. Usually appear first. Hyperirritability is the hallmark. Seizure, we found it in around 2% to 11%. The complication is low birth weight in 19%, respiratory complication and feeding difficulty also. So how to confirm it? The recent report has suggested that detecting drug exposure from umbilical cord tissue has similar sensitivity and specificity for meconium samples. A combination between maternal urine and neonatal meconium usually yield of the best results. The infant hair is the most sensitive, but not it's not used. And finally, we should talk about the Toxidrome. So after stabilization of your patient and initial diagnostic evaluations, look for the Toxidrome to narrow your differential diagnosis, especially for unknown ingestion. So we have group of anticholinergic. Usually they have delirium, mydriasis, hyperthermia, tachycardia, hypertension, tachypnea, dry flushed skin, dry mucous membrane, decreased bowel sound, urinary.
5 minutes more.
And the example for this is antihistamine. Opioid, everything is down, like sinus, depression, meiosis, apnea, and bradycardia, hyporeflexia. Example is heroin and morphine. Cholinergic, the example is organophosphorus associated with confusing meiosis, bradycardia, hypertension, hypotension, and tachypnea or bradypnea, depend on the severity of the disease symptoms. And example is organophosphate carbamates also as well. The sympathomimetic, everything is high, alert, hyper alert, agitated, hallucinated, mydriasis, hyperthermia, tachycardia, hypertensive, and management is benzodiazepine as well for everything. In sympathomimetic, one pill can kill. Children less than 10 kg exposed to the certain medication, they are risk for high mortality, like oral hypoglycemic, which is presented up to 18 hours. All patients should be admitted. Management with glucose initially, then consider octreotide if they have second attack of hypoglycemia. Beta blocker as well, calcium channel blocker, alpha-2 adrenergic agonist, cyclic antidepressant, opioid, salicylate, quinine, and camphor also. The risk of death is high. Camphor can cause seizure, intractable seizure. So in summary, please keep toxicology or toxicological causes one of your differential diagnosis. Usually approach like other patients systemically, A, B, C, D, and management of intoxication shouldn't usually is supportive. There is no rule for gastric lavage in pediatric age group, but it's still there in the adult. So thank you.
Thank you, Dr. Ismail, for this nice presentation.
Next speaker, Dr. Fadia Al-Khattabi. Dr. Fadia is a general pediatric consultant and child abuse at pediatric department at King Faisal Specialist Hospital. Also, Dr. Fadia is director of General Pediatric Residency Program. Dr. Fadia will talk about child abuse in Kingdom of Saudi Arabia, please welcome with me Dr. Fadia and start.
Sure. Yes, yes, I have. Can they put, this is not me. Yes, yes. لا بس هو خليه يحط البرزنتيشن أول شيء. بسم الله الرحمن الرحيم. السلام عليكم جميعا. Good morning, everyone. It's my pleasure to be here today. Thank you for the organizing committee, especially Dr. Afifi. And my title today is just about child abuse signs to watch out for. Especially my audience is an emergency physician and a frontliner. So we'll highlight in a few important points. We would love emergency physician to look after for the child abuse. So we'll describe an appropriate technique obtaining history and assessing physical finding. We'll talk mainly about sentinel injury in pediatric patient and what recommended evaluation. So if we go through the child abuse and a child maltreatment definition, WHO, it's contain all form of child abuse. And as you know, the four form, physical, emotional, sexual, and neglect. And in the definition, usually, if you look through that sentence, it's either resulting in actual or potential harm to the child health. So usually as a physician, when there is an actual harm, we act, but when there is a potential harm, when there is red flags, we're hesitant to report for many reasons. So I hope today my message, it will be noticing and identify the red flags and reporting those cases before the actual harm has happened. So why action need to be focused on children? Why we're thinking of child abuse? So childhood and adolescent are a period of vulnerability. Childhood is a period of exploration with increased exposure to risk. Neurodevelopmental, cognitive, behavioral changes are happening. And exposure to diversity in childhood may result in mental trauma and health harming behavior. Physical, family, social environment needs to be modified to ensure safety for children. So those all reasons, that's why we have to think about child abuse and child maltreatment. Does it happen in our culture and society? Yes, it's happened in all culture and in a different ethnic background, different religions, socioeconomics background, belief system, age, and the family types. So please don't be judgmental if sometimes you see in a patient in the ER in the clinics, family well dressed, look fine, the family, you know them for a long time, and then you think there is nothing can happen bad for the child in this family. They're well respected. So it can happen in all culture. It's happened in our society, most of the Gulf country. And the good news also, so there is a child abuse law was released in 2014 in Saudi, and all of us in Saudi were proud of that. And then there is a lot of implementation. There is a lot of movement in Saudi after the child abuse law was released, and also in most of the Gulf country and in the Middle East. Type of abuse, as we mentioned, the physical, the sexual, and emotional neglect. The most common form, it's neglect, but we talked mainly today about physical abuse. So reported of United Nations study on violence against children. No violence against children is justifiable, and all violence against children is preventable. So why I did child abuse and why I did it as a subspecialty and why I think all the time is a child abuse, why we're teaching physician about child maltreatment, because we should be an advocate for children. That's one of the things when we do as a pediatrician, and prevention, that's the main thing. So if we working on prevention, the primary prevention, secondary or tertiary prevention, and it's a huge topic. But the main message I want everybody to go with, it's working on prevention, identify the red flags, and prevent the harm from happening. How common? And there is a lot of even in the studies in Saudi and international. This study by Dr. McMallan, she's a child abuse pediatrician in Ontario. It's an old study, but that survey was done in an adult, and it's showing 10% of adults they're reporting a history of severe physical abuse during their childhood, but they never told anyone. And 11 and 4 men reported of a history of severe sexual abuse during their childhood. So it's a common. It's almost like in a childhood asthma. Reporting system, whatever, this is an international conference, so that's why whatever your country, your background, just look for the reporting system. In Saudi, after the child abuse law was released, the Ministry on Labor and Social Development, the Protection Center, we have around in Riyadh region, for example, more than 9, I think more in the kingdom, around 24 child protection center, and they have the toll-free number 1919. And they're receiving call 24/7. You can call them if you're in your clinic in the emergency. But they advise you always, if you have a child abuse team in your institute, and if you have an expert in your area, just contact them, take some advices, and child abuse team in the institute, in the hospital, they can take over the cases and help you in the management and the process later on. This is the phone number, the email. Also, you can send them the email. There's a special form. You fill it with the patient identification, and then just send the report, and then they will email you back with a case number. So later on, as a physician, you can follow with them and get some update about the cases. So why some professionals do not report, and they're hesitant to report for many reasons. One of it's lack of confidence in investigatory systems. So they're saying many times, we're reporting those cases, but nothing happens. It's useless. Why I'm doing this? But keep in your mind, it's in some countries, it's still primitive. It's in the system, it's well developed. And even in North America, with the history of 40 years or more of child abuse, and teams and management and well-established system, still there's some of cases they don't they're missed in the system. So reporting those cases where our social worker and the protection system, the legal enforcement, and all the people that are working, because it's a multidisciplinary team, it's a learning process. So I think we're improving the system by reporting cases and instead of not reporting. System doesn't have an adequate resources, and this is an all over the world, like in enough sources of therapists, family therapists, enough psychologists after we diagnose those cases. It's present in all over the world. Lack of confidence in diagnosis, and that's what we'll talk a little bit about it today, about recognizing at least the red flag. So you don't have to be sure 100%, but if you have any suspicion, if you have a reasonable doubt to report those cases, go ahead and report it. And as I said, if you have an expert in your area, just report those cases. Difficulty in abuse happening in the present in the family. Pediatrician, we have that bond with the family. We like them, we like the parent, we know them for a couple of years, so always we're hesitant to report those cases. Discomfort in confrontation, usually as people we don't like, as we're like a physician, we're not trained to confront family, but communication and how to communicate with the family in those scenarios. Also, this is another skills you have to learn. If you don't know how to do it, just ask the expert. And if you don't know and you don't have an expert, just report it to the protection center, and they will help you how to confront them. Ensure your safety prior to do that. Reporting violation of confidentiality, and that's not true. Usually this is we're obligated by law, and in the majority of our countries, to just report those cases. And fear of legal sequences, and people, they're gonna sue me. Never. If you're having reasonable doubt and if you have a suspicion, that's the child right, and you're protecting kids. And time demands, definitely. That's why if you have a child abuse team in your center, if you have a well-established team or a committee, just refer those cases to them so they can help you. Because especially are the people, they're busy, they're having a lot of cases. So just refer it to the team, and they will take over from you. The challenges for healthcare professionals, so challenges usually in recognizing, identifying those cases in the communication, as we mentioned, and also interpreting the physical finding. There's a lot of indicator of child maltreatment if you look at the history from the medical history, and you remember always you're a physician. So injury does not consistent with the history provided. The mechanism of the injury, the amount of force, the age and developmental stage of the child, that's really important also. Inconsistent of the history and history changing, delay in seeking medical attention, multiple injuries, injuries of different ages. So there is always red flags. Majority of our cases, not black and white. If it's black and white, that's a lay person in the street can tell you this is a child abuse case. But see, there is always, they're always in the gray area, and you have to notice the red flag. And as I mentioned, working on prevention. So taking a medical history, as a physician, taking all the details, what happened, who was there when it was happened, it was witness and witness injury, where did it happen, and when it was happened, and what happened afterward, and when was the child noted to be ill or injury, how did the child respond at the time he was crying, mom, she soothed him, fed him, put him in the bed, and when the start of the symptoms, for example, if the child fell and he has an femur fracture, so the swelling, when the swelling, the symptoms was started, and how did you respond as a parent? Did you call an emergency doctor? Did you seek a medical advice? And what made you bring your child now to the ER? Past medical history, always I'm telling my student trainees, remember you're a physician, so always take a detailed history, because you're ruling also other pathological causes and mimicking causes of abuse. So birth history, prematurity, previous health problem, bleeding tendency, bone disease, dietary habit for the fracture, calcium and vitamin D, history of previous injury, ask for the past period of fussiness, irritability, lethargy, developmental history. It's a very important, and child general temperament, and then how is the behavior of the child. Family history, also social history, definitely it's important. And if you're in an ER setting, utilize always the social worker. And attitude, how the majority of our physical abuse, and then there's a good percent, especially in our culture, maybe that's not studied in our culture, but attitude toward the child, discipline, how you discipline your child and what you're doing, that's another area we can work as a pediatrician and by educating the family. Physical also exam, completing physical exam, completing skin exam, head to toe. That's the other thing you have to do with document. And remember your medical history, your physical examination, it can be used later on with the legal enforcement if there is any charges would be pressed. I will mainly focus today about bruises. So it's caused by blood leaking out of the capillary into the surrounding tissue. Color of bruises change as blood is broken down. There is many factors of the bruises color, including the location, the depth, and the skin color. There is an old study by Dr. Sugar and her colleague in the 99, and that's they took in the Well Baby Clinic 1,000 children from 1 month to 36 months, and they tried to notice the bruises in children. Physician noticed that the bruises in diagram, it was very rare if they're pre-cruises. So those who do not cruise rarely bruise, and you have to keep that in your mind. In your ER setting, in the clinics, if you notice any bruises in the children less than 6 months or less than 4 months. Bruises in toddlers are rare, and also in some location like face, trunk, and hands and buttocks. Dr. McGuire and her colleague also, the same studies, bruises in non-ambulatory infants, it's very uncommon. Uncommon location, also area and bruises, it's uncommon, back and buttocks, forearm, arm, face and abdomen and hip. And if you think about this location, it's usually soft and cushioned, so there is no bony underlying. So the amount of force to generate that bruise, usually it's a significant amount of force. So if the 3 months old covered with the bruises in the abdomen and the face, and mom, she's telling you, and the caregiver, that the 18 months old did that, you have to have some suspicion, because the amount of force was generated to develop those bruises, it's significant. Pattern bruise also, multiple bruises in cluster, multiple bruises in uniform shape, bruises that have shape and objective of ligature mark, that's also a concerning. So the red flags for bruises, the age and developmental level, you have to ask exactly the age of the child and the developmental, what's capable the child to do, especially in kids with the disability, and then what a gross motor and fine motor and what's developmental history that can do it. Location also, as we mentioned, and it's a very rare and less common in area, well, caution area, and the pattern bruises. So thoracic and abdomen bruises, it's concerning because the location, as we mentioned, the abdomen, it's a soft and cushion. Two linear bruises. What do you think this one? Slap mark, exactly. So there is the two linear, it's a crushing of the capillary vessels between the fingers, and this is a very typical of slap mark, or it can be also hidden by object. Abortic bruises. So if you can see, there is two linear bruises. And also a multiple linear bruises with a lot of petechiae. The buttocks, as we mentioned, it's in a very soft cushion area. Also, it's concerning for an accidental injury. Ear bruises. Why ear? We're concerning. It's a cartilage. Kids, when they usually fell, they usually protect themselves when they're mobile. And the mechanism of action of this: pulling, tugging, or direct blow. It can be. Tiny baby, always I'm telling people they have tiny bruises. So if you have 1 month or 2 months, the bruises, it will not be big. So if you notice any bruises, you have to have a good history and mechanism and what happened, and thinking about an accidental injury. That's the back of the infant also with the two linear bruises. Dr. Mary Priest, in 2010, they started to have that PCDR, which is a bruising clinical documentation. And the abbreviation that's give you a hint that's the highly suspicion of the TN4 phases. That's a highly suspicion for inflicted injury. So TNN, it's stand for towards the trunk, so chest and abdomen, back, ear and neck. And this is common if it's present in the children less than 4 years, you have to be concerned. And 4, it stands for any child with less than 4 months coming with the bruises, you have to think about non-accidental injury or inflicted injury. And face, frenulum injury, ear injury, cheek and eyelid and sclera. And this is another face injury in less than 3 months old, so you have to be concerned. Frenula, there is a granulation. We have a 3 frenula in the body when you're examining the upper lip and the one connecting the upper lip with the gums, the lower and the upper, and also under tongue. So the mechanism of injury here, it's what do you think? So it's forceful feeding, excellent. So forceful feeding, especially in the infant, less than 6 months, fussy baby, a single mom, she doesn't know how to deal. And also, so what another mechanism, it's inserting a sharp object. It can be some cases we saw. So for example, one case of present, if you have a 3-month-old girl brought it to the ER by parent, excessive crying for a few days, today was feeding well, parent concerned about dehydration. So they brought her to the emergency room because they're concerned about dehydration. Parent also report scratch and bruises, but marks usually lasted only 1 day, no family history of bleeding and bruises. Sorry about the picture, but she had a cheek bruise, rounded cheek bruise. If it's clear, and also this is the knee, so and also a small knee. So she's 3 months old, coming with the bruises in the cheek. The explanation provided by the parents from vigorous sucking on the soother, the bruises on the cheek from turning head and bumping into the soother, and the bruises on the knee from lying prone. So this mechanism, do you think it's unacceptable? So you have some concern, but they came mainly for what? For dehydration. So they didn't show up for the bruises. So here there's another important topic, and there's another important thing we call it a sentinel injury. So what is sentinel injury? It's any previous injury visible to the eye reported in the medical history by caregiver or a medical provider that was suspicion for abuse, bruising, frenulum tear, all those injuries. So it's a visible, otherwise detectable. It's a minor injury, so it's not that significant injury. Usually it's common in the pre-mobile infant that poorly explained, therefore concerning for child abuse, often clinically insignificant from treatment perspective. So those bruises in the emergency setting, you will not do anything. You're treating the dehydration, so you're not concerned about those bruises and heal quickly and completely without any direct sequelae. So in that study, when they talk about sentinel injury, breaking down the location, so 80% of the bruises, including subconjunctival hemorrhage. So the bruises was most common sentinel injury, followed by the intraocular injury and fractures. One of the cases illustrated in that paper, 2-month-old infant admitted for becoming limp and unresponsive at home, was found to have subdural hemorrhage, extensive retinal hemorrhage, and healing fractures, diagnosed with abusive head trauma. So 2 weeks before, his mother had noticed a bruise on his cheek, and he was seen in Will Baby Clinic. The majority of the cases during my training I saw in the autopsy table, they've been seen multiple times by physician, nurse practitioner, social worker, and no one noticed in reporting those bruises on those injury. So in that paper, there is a 400 infant less than 1 year, and around 27% of the infant definitely having abuse cohort, and around 40% medical provider. Sorry. A medical provider was aware of the sentinel injury. So they're aware there's some sentinel injury. They noticed the bruises. 10 out of 23 medical providers suspected child abuse. So they have some suspicion, but they didn't do anything. And 13 were there no evidence of such suggestive provider or they suspected child abuse at that time. So the history of sentinel injury should be promote a medical provider in any setting to concern about abuse and improve detection and management of minor injury in an infant has a potential preventing around 27% of abuse cases evaluated at a tertiary hospital. So noticing the sentinel injury and trying to prevent the harm and serious injury like an inflicted abusive head trauma and then the impact, the huge impact and then the developmental on the child, or it can lead to death in some of the cases. So prevention, that's main things from identifying those sentinel injury. So bruises is a trauma. So you're in an emergency setting, you're doing ATLS, you're dealing with the trauma, primary survey, secondary survey. So acting on those cases, child maltreatment, it's like an acting on a trauma case. So you need to have all your initial assessment and then acting on those cases medically, and then you will dealing with other non-medical team. So history is very important. And as we mentioned, looking for the indicator, looking for the red flag. History and injury and psychosocial risk factor. It's a very important among cases of fatal and near fatal of physical abuse. There was a study on 20 children less than 4 years, and the median age was 7 months, and 95% of those kids, they're having a traumatic head injury, and 90% they're coming with the bruises. And 64%, they had a prior atypical bruises, but no one did anything at that time. So sentinel injury, it can be recognizing symptoms. Who might think? The caregiver, the parent, the medical provider, family member also, they can notice. Social worker with you in the team, and social worker in the school also. Type of injury, bruises in infant, intraoral as we mentioned, and ear injury and subconjunctival hemorrhage. Abusive head trauma also, they can present it, as I mentioned, and that paper, the same things and cases was missed initially with the bruises, and also missing diagnosis of abusive head trauma. That's another topic and huge topic, but because their symptoms, it's non-specific and consistent with common illness, they're presenting with vomiting, irritability, and lethargy, and history of injury, usually it's not provided. And in that paper also by Dr. Carol Janney, which is a famous child abuse pediatrician, she has an excellent textbook. It's very simple. Even you can look at it and just having an excellent reference. So in that paper, kids less than 3 years, around 30%, they're having evidence of misdiagnosis by physician in the ER setting, and also a missed and then they came with a re-injury and delay in diagnosis and came initially with a sentinel injury. So recognizing the urgency of those sentinel injury, if you want, it's depend on the setting are. If you have a child abuse team, you can call them, admit those children sometimes for safety and for investigation. Workup on an occult injury, so you complete your workup, doing a skeletal survey, recommended for all kids coming with the bruises, and then especially kids less than 2 years. Older, it's dependent on your clinical examination, developmental age of the child. Sometimes we're doing something called partial skeletal survey, so we're doing a skull and a chest, especially in the mobile children. So we're looking for a skull fracture and then healing rib fractures. Neuroimaging, it's a recommendation for all children less than 1 year, especially less than 6 months, even if they don't have any neurological symptoms, but they're having a sentinel injury and bruises. So doing CT and MRI. CT is fast and quick in the emergency setting, MRI later on just as a follow-up. Retinal hemorrhage also, looking for that, and then doing an eye exam, looking especially in an infant less than 6 months. ALT, AST, and amylase and lipase, just looking for an occult abdominal trauma. And the sensitivity and specificity for an ALT and AST, if it's more than 80, that's a give you just highly sensitivity and specificity of occult abdominal trauma, and going with an abdominal imaging and ultrasound or CT. Good history and then a good explanation of the incidents, the injury. That's the most important thing also. So sentinel injury common and hospitalized severely injured children, infant. Most of sentinel injury occur before 6th of month, and at least in the mobile and the differential between accidental and inflicted injury are more straightforward. The average window between the sentinel injury and the hospitalized severe injured child around 1.5 months. And the accurate diagnosis is usually prevention. So prevention. There's a few tips and rules for a physician. At the end, I want to highlight an emergency physician clinician. Usually in the child abuse cases, don't assume what happened. Just stick your role. I tell my trainees and students, you're not detective. We didn't train you to be a detective. You're a physician. So, but in these cases, you're working with the multidisciplinary team, with the legal enforcement, with the social worker. So usually try to get your part and then handle the medical information by non-medical language to those our colleagues in the legal enforcement and the social worker to try to help the child. So
5 minutes more. Huh?
sure. So don't usually think of the intent and who did it and what's happened. So stick to the medical history. Don't draw on your version of the history. Limited your medical opinion with your evidence, with your investigation. There is a lot after the child abuse law was released, and here in Saudi and also in multi countries and then even North America. Custody and access cases, I hate it, and it's usually difficult, and the victim usually is the child. So please, in the ER setting, be careful about the documentation or in the clinic that you provide to the family. So after the visitation, what happens sometimes, they spend the weekend with one of their parents, and they're coming to the emergency physician accusing the other parent. So be careful about what exactly medical documentation. It's very critical. It can use it they can use it in the court, in the custody. And if it's happened more than one time in the emergency setting, please report it to the child protection, because there's an emotional harm affecting the child later on. Be supportive, even if the child is coming with a severe head injury, very sick and then a critical. They're the parent. They're still the mom, dad. They love their children. We don't know who did it, so we provide them with full support. Provide them with updated with the case and the information, medical information. Don't become an investigator. Don't interview the child if you're not trained to interview children and then child maltreatment cases. Do not do it, because sometimes it can contaminate the investigation later on, and it can have some you're re-traumatizing some of the children. So if you're not trained, don't do it. Social worker, always helpful, so use them, utilize them. Don't provide, as I mentioned, any letter unless you're getting from the legal enforcement or a place, they ask you officially to through your administration to provide them a letter, and consult always the child abuse program in your team. So the solution of the adult problem tomorrow depends in large measure upon the way on children grow up today. Thank you very much. If you have any questions.
Thank you, Doctora, for this informative and great presentation. Next speaker, Dr. Sami Al-Haidar. He's a speaker from Saudi Arabia, King Faisal Specialist Hospital and Research Center. Dr. Sami is a physician educator and consultant pediatric respirologist, intervention and pulmonologist, pediatric department, King Faisal Specialist Hospital and Research Center, associate professor pediatric in Faisal University, executive director of training at Saudi Commission of Health for Health Specialists. We are today, he will sharing us his talk about bronchiolitis management and practice approach in Saudi Arabia. With that, we expect to give your attention to Dr. Faisal and helping us to welcoming to this stage, Dr. Sami.
Thank you so much. بسم الله الرحمن الرحيم. أسعد الله صباحكم جميعا بكل خير. Thank you for the organizing committee. It's my pleasure to participate in this great conference. This is the 7th year, in spite of all challenges we are facing in our healthcare system, going over the pandemic. This conference has been a great success. Alhamdulillah, we are back to our live interactions. Hopefully next year we will be more crowd in the room. I welcome my colleague in the stage and in the conference room, as well as the huge participant over the virtual connections. So my topic is to go over practical approach for a subject that is very common for pediatricians and general practitioner, nurses, respiratory therapists, and even parents. We are just almost over the winter season, where infant toddlers go over a challenging situation called bronchiolitis. So hopefully by the end of this presentation, you will have a practical approach touching some bases in the updates for this common topic. Little disclosure, I have some non-related disclaimers. I don't think it has a direct relationship to the presentation. So hopefully the outline will cover some etiology, pathophysiology, the burden of the topic, diagnosis, management tips, and then to go over the most important aspect, which is the prevention part of bronchiolitis. So bronchiolitis, based on the American Academy of Pediatrics definition, though it is a pathologic term, its definition is basically a clinical description that it is a viral lower respiratory tract infection involving children with specific age group. It has been defined as less than 2 years of age, characterized by increase in respiratory efforts, tachypnea, wheezing, and or crackles on chest auscultation. And it follows a few days of prodrome of rhinorrhea, cough, and occasionally fever. Though I have, as a subject, probably expert in respirology of pediatrics, I have reservation on having some restrictive definitions. I don't think 2 years of age making a big sense, especially for the general practitioner. A kid who is 2 years and 1 month still can have bronchiolitis. And so I think the message here is to remember why there is an age group for bronchiolitis. Actually, even adults can get bronchiolitis. They can get the pathologic component of bronchiolitis, which is the inflammation of bronchioles. However, the clinical constellation is limited to a small age group, not due to the age group. It's due to the physical size of their airway. So if you got a child who has, for example, Sentinel syndrome, they could have bronchiolitis with their viral infection. Or if you could have a child who is a failure to thrive, where their airway caliber is so small to be in that normal 2 years age group, then bronchiolitis should be in your differential diagnosis. So this is something I have seen in my colleague, especially resident and nurses, where they exclude the clinical presentation of bronchiolitis. Now, it's very interesting, old, well-known virus. It's very interesting how coronavirus is giving us a new insight, how we look to something old. So it is a single-strand RNA, so something common like coronavirus. It has been very challenging from the point of immunogenicity and even coming up with preventive vaccine. So that aspect is important when we come to the preventive measure later on in this presentation. I think it's very important to remember why those younger kids suffer from bronchiolitis. Basically, it's the inflammation involving the respiratory tract. And again, this is something we have to be aware of. It's not related to the bronchioles. It's actually the respiratory system from the nose down to the alveoli. It's true that the most prominent part is the bronchioles. However, for example, the nasal obstruction plays a major role in the suffer of those kids. So there is no geographical landmark for the virus just to affect the bronchioles. So we have to remember when we entertain a virus that even gastritis can be among the presentation. Vomiting due to irritation of stomach can be a presentation. So, however, the respiratory prominent feature, which lead to the severe, moderate to severe presentation, which lead to admission, is commonly due to the severe effect on the bronchioles, where there is neutrophilic inflammation leading to airway edema, effect on ciliary function, mucus production, and even that will affect in that evolving kid, in particular, the coordination between neuro, respiratory, and even alimentary tract, make them more prone to have more complication of this lower respiratory tract infection compared to other age group. So they are prone to have, to lose their equilibrium. They are prone for aspiration. They are prone for dehydration. They are more prone to get even a small reserve for their respiratory systems. That's why they get more desaturation if they are among the severe presentations. The burden is huge, and this is why I think our international conference in emergency medicine is focusing on this due to the major burden, whether it is among the pediatric practice or for the acute presentation, because clearly bronchiolitis is something related to acute care when those kids present to our healthcare facilities. So it's a main cause of acute lower respiratory tract infections in children worldwide. Annually, there is more than 30 million annual pediatric lower respiratory tract infection due to bronchiolitis. It leads to a hospitalization in a small portion of patients, less than 10%, in some cohorts 3%, some 6%. And even from those small portion, there is another 2%, 2 to 6% who will require intensive care attention in our health care facility. It's not simple in certain patient population. It can lead to mortality. So there is an estimation of more than 50,000 in-hospital deaths per year due to bronchiolitis. 45% of hospitalization is related to a specific age group. Within this age group of bronchiolitis, who are the kids less than 6 or 3 months of age. And this is going to come back when we are identifying our risk factors in kids presenting with bronchiolitis. Among the causes of bronchiolitis typically is all different kind of viruses. However, RSV, the respiratory syncytial virus, continues to represent almost 80 to 90% of presentations, especially for those admitted in hospitals. And that which make RSV infection within the presentation of bronchiolitis among the top targets in our diagnostic and therapeutic and even preventive interventions. There is seasonality, and this is something you have to be aware of. And that kind of seasonality varies based where you are in the hemisphere, whether you are in the northern or southern hemisphere, and also due to some geographical distribution, and it also varies from year to year. In general, this has been studied even in our country, and it starts in mid-late October till early mid-March. And this is where you can see in the graph the three bars of RSV. However, as you can see, there is a whole set of dynamic viruses going over throughout the year. Again, this is not to say bronchiolitis cannot happen beyond this period of time. However, this is the common variation where the incidence is going to be high, and this is where we need to be ready in our facilities to handle those kind of patients. Again, pathophysiology and research and studies have shown that there is a multi organism involvement, so it's not necessarily a single organism. Still, and as you can see in this graph, RSV represents the commonest identified virus within patient admitted. And as you can see, next to the blue bar, there is a red bar which represents the other identified viruses. So with the advancement and the sensitivity of our PCR and other kind of testing, we are more able to identify coexistence of different viruses, which represent an interesting research area to study whether there is a particular interaction between the two pathogens. So you have to be also aware of the high-risk infants. So when you see a child who presents, or even if you get a virtual tele-clinic consultation, which is now very common for us, you need to identify who are the kids who will be among the high-risk group. So kids with chronic lung disease, especially those who fulfill the definition of bronchopulmonary dysplasia, congenital heart disease, especially the cyanotic one, neuromuscular disorders, especially if it's affecting their ability to cough. So if their natural mucociliary clearance is defective, they are going to be among the high-risk group. Kids with immune deficiency, extreme prematurity, and as we mentioned before, if it's within the first 6 or 3 months of life, due to both the size of the airway and the evolving immune system to protect themselves. Now, the hospitalization indication, whenever there is increase in the respiratory efforts, respiratory rate more than 60 breaths per minute for that particular age group, if there is a marked chest wall retractions, if there is decrease in peripheral oxygen saturation, if they present with central cyanosis, presence of apnea, which could be related to both obstructive due to the secretions, or even central apnea due to their growing and evolving central nervous system, poor oral fluid intake due to breathlessness. Now, moving to diagnostic tips, I think I will go over prominent features where there is some confusion. Diagnosis of bronchiolitis has been and will continue to be a clinical diagnosis. There is no need to do chest X-ray routinely, or even do any laboratory working, including blood gases, if the presentation is typical and fulfilling the definition of bronchiolitis. And so it's very interesting how throughout 2022 we are still relying on our human skills in terms of history taking and physical examination. In terms of management, again, there is still confusion toward what we are supposed to do. We should not use albuterol, epinephrine, antibacterial medication, or even supplemental oxygen routinely. Epinephrine can be definitely used if those kids are presenting in a situation where resuscitation is required, which can be related to other causes. Antimicrobial agent should not be used routinely unless there is evidence of concomitant bacterial infection, which can be identified clinically and proven by biochemical markers. Now, the oxygen supplementation, it's again another area. It has been among the reasons for over-hospitalization and over-observation. And there is a growing evidence that even continuous monitoring is not required for those patients, except if they are dropping their saturation and if they have risk factors, the underlying heart disease, immune system dysfunction, or extreme prematurity, and underlying hypoxemic lung disease related, for example, to the bronchopulmonary dysplasia if they are premature. It's also interesting during preparing for this presentation that the latest guidelines has been for a while. The famous American Academy of Pediatric guideline has been updated last time in 2014. So it seems to be it's really outdated. And so I have been through some recommendation. The prominent one I will go over is the use of hypertonic saline. And so since that guideline, there have been evolving evidence with strong papers coming from systemic review and meta-analysis addressing recommendation that might not be in alliance with our gold standard guidelines. For example, using high flow nasal cannula, it has been evolving over the past decade, and this is a very interesting intervention. Coming from adult use, high flow nasal cannula is a technique where you can have a humidified high flow air that can reach up to, for example, 25 to 30 liter per minute. And that will add not only oxygenation option, but it will provide sort of positive pressure support, similar to the continuous CPAP or positive airway pressure. And so using high flow nasal cannula, especially with the improvement in the technology and the devices that is licensed for pediatric and infant use, I think it's something that we are going to see more. We have witnessed over the last decade, high flow nasal cannula has been restricted to ICU setting, and now in most hospitals, it is a ward routinely used intervention, and we have even patients use high flow nasal cannula at home setting. So this is something just to consider, because there is evidence, for example, it will improve the outcome, reducing the treatment failures, and even it minimize the hospitalization or length of stay in the hospitals. Use of continuous pulse oximetry should not be used routinely. Chest physiotherapy should not be used as well routinely, except if there is evidence of atelectatic changes or collapse in the airway. Otherwise, we should do supportive care with no irritative interventions to the child, because they are struggling to maintain themselves during this difficult time. One of them, clinical and practical tips, we use as pediatricians and even nurses to keep those kids MBO, because they are tachypnic and we are afraid of aspiration. Now, the recommendation is to continue feeding through a nasogastric tube. So it has been linked to better outcomes in terms of hospital stay and even escalation for high critical care monitoring. So nasogastric tube should be the priority in terms of hydrating those kids rather than keeping them MBO on IV fluid. Another area of interest in bronchiolitis is using the hypertonic saline. And so using hypertonic solutions rather than normal saline has evolved in respiratory care over the past 3 decades. There is evidence in cystic fibrosis use. It is now a gold standard in cystic fibrosis, and it has been also evolving in bronchiolitis. And the underlying pathophysiologic mechanism is that hypertonic saline will hydrate the airway mucosal layer. Because though there is infection and plenty of secretions, however, the water layer in the mucus is dry, and there is increased viscosity of the secretions due to the lack of more hydration of this mucus layer. So hypertonic saline will help to hydrate the airway, and that in turn will help to clear the secretion and to improve the mucociliary function of the airway. However, the initial studies and in return the recommendation in American Academy of Pediatrics has shown conflicting recommendation. And the recommendation in 2014 was not to use it in emergency and to use it only for hospitalized patients, especially if they are staying more than 1 day or even 3 days. Since that time, I have been through many paper comings, and there is few I will share with you some resources, including meta-analysis. It's now showing more and more that hypertonic saline is really effective, especially in decreasing the rate of hospitalization, decrease the length of hospital stay, and even decrease the severity scores of the illness. And I think from my humble reading and a review of literature, the control arm was not fair for hypertonic saline. Most of the studies, they used normal saline in the control arm. And so the hydration concept has been addressed in the control group to start with. So I think it will be more probably proper to have an intervention arm with a control group where the guideline was recommending nil use of nebulization or inhalational therapy. So I think this is part of the confusion we had in the initial studies, that the comparison were made with an arm, controlled arm, which is already getting some effect from the 0.9% sodium chloride solution. This is one of the JAMA published papers in 2014 after the publication of the American Academy of Pediatrics, and it showed clearly that the collective effect of hypertonic saline 3% is toward reducing the odds ratio of admission. So that is in favor of using hypertonic saline in even emergency. This is another recent meta-analysis in 2020 in Journal of BMC Pediatrics, and it showed that the clinical severity score, as you can see in the forest plot graph, it's reduced the odds of the severity score of the clinical, and even using another severity score, the respiratory distress assessment instrument, which is another validated clinical severity score, it showed reduction in the arm of 3% nebulized hypertonic saline. It has also a positive effect, clear positive effect with statistical significance on the hospital stay. So the length of stay can be reduced by 0.5 to 0.75 days. It might sound a small effect. However, this is very crucial. Those of you working in emergencies, they know during the peak of bronchiolitis, you would like to get patient as soon as you can in order to get the turn and the flow from emergency department for those need admission. The same thing also on the rate of hospitalization. So it can reduce, though this effect is not major. However, it is also statistically significant that the rate of hospitalization will be reduced. In terms of the rate of readmission, there is effect. However, it is not statistically significant. And this might reflect the underlying host factors. So those who are going to be readmitted due to their underlying hypertonic saline might not be the sole solution for their issue. What's nice about this study, they looked also for morbidity factors like the quality of sleep. And so there was also a strong effect on the time of sleeping. Those who got hypertonic saline, they will get longer sleeping time. Even the quality of sleep, the rate of waking up at night is less if they are using hypertonic saline, which is also an interesting, and it should have an effect on their health and recovery. Now, moving from management to prevention, and I think this is a very important aspect. And before we close our presentation, the basic recommendation is going to be effective. And I don't think I need to re-endorse or enforce this after the pandemic. Everyone was shaky about handshake washing, about the distancing, and about wearing masks. I think everyone in the community now believe big time in those interventions. So it is the time to say it is effective. So let's stick to it before we talk about the advancements in medication and in vaccination. So disinfect your hands before and after direct contact. Use alcohol-based rubs or even hand washing. It's very important to educate parents and caregiver about the effect of tobacco smoking. So it is well documented that the severity score is directly related to the passive and active exposure to the environmental irritant, and the commonest one is the cigarette and tobacco and shisha exposure. We have to encourage breastfeeding, and I think this is very important. And evidence is there. At least 6 months of breastfeeding is going to be more effective than considering immunization to prevent severity of illnesses that requires hospitalization. I think it's also important to talk something about available preventive intervention. The famous and the one which has been used for a long time is the monoclonal antibodies, bevacizumab. So bevacizumab is a passive immunization. So it's a pre-made antibodies. It's expensive. That's why it is a restrictive prescription based on criteria and privileged prescriber. And there have been national and international recommendation. So for hemodynamically significant patient with congenital heart disease, they qualify for bevacizumab. Kids with chronic lung disease, especially if they are preterm with gestational age less than 32 weeks, American Academy less than 29 weeks, with oxygen requirement, which qualify for bronchopulmonary dysplasia, which means they require oxygen more than 21% FiO2 beyond 4 weeks of life. So they will be qualified, and those qualified infants, they will take minimum 5 doses during the peak time. It is given over a period of 4 weeks. So we give it monthly during the peak season from October till March. And it is very effective to prevent or minimize the severity of disease once it is happening. There is interesting news coming. I was just last night considering, is there any advancement in messenger RNA vaccines for RSV? And I was really amazed. I didn't know this except last night. So there is early stage data from phase 2 trials, some in older adults and some in younger adults. It suggests that the vaccine will be safe and effective. Both Janssen, Pfizer have run small-scale challenge trial exposing vaccinated younger adult to RSV and have shown that vaccine protection rate is high. There is 4 companies working on this: Janssen, Moderna, GSK, and Pfizer. And it's really interesting. Some of the pre-published data, it showed 10 to 15 or 14-fold immunogenicity. Again, it is following this new technology. I think COVID-19 has smashed the concerns about messenger RNA use. And so I think that will make it maybe sooner. So if you just Google it, if you look for Nature publication and Lancet publication, there is even expectation that maybe FDA approval will come during 2022. And this is something really going to be very interesting.
5 minutes more.
Sure, I will finish in 1 minute. So I thought this is something you would like to be aware of, something in the pipeline. And I hope we will be looking soon for good news in that aspect. Finally, I think also it's good to do some reflections on the collateral effect or impact of COVID-19. Children and younger people have been observed to account to a small portion of COVID-19 affected population. Though this has changed toward the end of pandemic, where the transmissibility of the COVID-19 was observed to be high among kids. However, alhamdulillah, the good thing, it continued to be a mild form of infection. We observed in our clinic, I am sure all of you, for me in pediatric pulmonology clinic, 2020 and 2021 were the smoothest experience for our patients who have lung disease. The rate of infection were very low. Influenza and bronchiolitis has been projected to be low even scientifically. And I think this is justified by 2 things: by the isolation that the community was applying, but also due to the preventive measures. Everyone was washing hands, avoiding close distance, using mask. And I think we should be taking two major messages. First, we have to continue advertising for those protective messages. And the second thing, I think we should be ready for a tough winter season next time, because people now are coming back, undermining those measures, and the herd immunity in the community is going down toward influenza, because memory cells is away for 2 years from those infections. So I think we have to be anticipating and proactive toward the impact. There is also a general pediatric effect that is very concerning. And I know there is national efforts from our expertise in general pediatrics and infectious disease. There was a very concerning drop in the national rate of immunization, because people were at home, and kids in the first 2 years, they were away. Meningococcal, pneumococcal, other viruses, MMR and varicella, and even influenza vaccines were the least, I think, from our observation. I will be interested really to see some studies comparing this phenomena, but I think this is something would enhance a national move to recap and capture this drop in our compliance with vaccination. I would conclude with some resources. So there is an excellent, as I mentioned, it's still a very excellent paper from the American Academy of Pediatrics, though it's a little bit outdated. This is one of the meta-analysis I would really highly recommend for everyone to go and read, published in 2022. This is a national guideline that has been published in 2018 by the Saudi Pediatric Pulmonology Group. It's an open access. I highly recommend every pediatrician to have this in his folder. And thank you so much for your attention.
Thank you, Dr. Sami, for this great presentation. The next speaker is Dr. Mohammed Al-Awain. Is a professor, Department of Anatomy and Cell Biology, College of Medicine, Al Faisal University, Riyadh, Saudi Arabia. He's the chairman of the Department of Medical Genetics of King Faisal Specialist Hospital and the Research Center. He has American Board of Pediatric and American Board of Biological Genetic publication. His publication about 135. Today, he will share us his talk about inborn error of metabolism and our experience. With that, we expect to give your attention to Dr. Muhammad and helping us to welcoming to this stage, Dr. Muhammad.
Assalamu alaikum. Hayyakum Allah. It feels weird, you know, with the hybrid empty auditorium and speaking in front of. Anyhow, today I will be talking about metabolic diseases. It's a different mode of thinking. Briefly, just the basic about the inborn error of metabolism. Usually it's due to an enzyme deficiency, and the pathogenesis results from either excessive accumulation or deficiency of the product or deficiency of the excessive accumulation of the substrate or deficiency of the product. We, you know, like any other specialty, we tend to classify our disorders organic acidemias. If you want to get anything from this slide, propionic acidemia and methylmalonic acidemia are the most common in Saudi Arabia. And then urea cycle defects is a very important entity, and then the other disorders as well. The key thing for an emergency physician is how these patients present. Encephalopathy is the main presentation that you guys have to worry about. Three entities that you have to know: hypoglycemia, metabolic acidosis, hyperammonemia. These are going to bother anyone working in the emergency room dealing with metabolic patients. And then the chronic, muscular storage, we will not, stress on for in this presentation. Now, encephalopathy, because the main problem when you deal with a child who is encephalopathic, you don't know, the cause, and you want to act, promptly and accurately. So, three main disorders that we'll look into are the urea cycle, the organic acidemias, and then some other disorders like mitochondrial fatty acid oxidation defects. This child that is who is shown in this picture, for example, is an encephalopathic metabolic child. They come with a history of lethargy, poor feeding, apnea or sometimes tachypnea, recurrent vomiting, and then you do the acute labs, and then you find them having either high ammonia or severe metabolic acidosis. They can have metabolic stroke, if you do a CT scan or, if you review their MRI, and it tends to be in the basal ganglia. And many times we deal with these children in the hospital with, please don't change the slides, I will change them. You deal with these children in the hospital, and they have either peritoneal dialysis or hemodialysis. Hypoglycemia is also an important picture, but I think emergency room are well equipped to do on-spot glucose, so they know how to act on it. And there are certain disorders that come to our mind, like glycogen storage disease, gluconeogenic disorders, and fatty acid disorders. Sometimes, away from acute encephalopathy, you can have a child with liver failure. That is due to metabolic disorders. However, they normally don't present in a severely acute situation like the previous entities, but galactosemia, hereditary tyrosinemia, occasionally neonatal hemochromatosis, although rare. This is a child with tyrosinemia presenting with fulminant hepatic failure. But I think you have plenty of time to consult metabolic service, to help with the diagnosis. How do we make the diagnosis? You may wonder how the diagnosis is made. And very simply, you can use biochemical diagnosis, or you can use a DNA-based diagnosis. And in this picture, for example, at the top, the DNA, which now is actually a revolution in terms of diagnosis. We don't expect people in the emergency room to order this or know this in details, but that is the mainstay now of our diagnosis. Or you can do at the protein level, where you do the enzyme assay, or you can do at the metabolite level, you do the substrate and the product, and this is what we do whether it is in the emergency room or in the hospital setting. This is the urine GCMS, this is the GCMS machine that is used for urine organic acid analysis. One of the key things that we use for biochemical diagnosis. And this is amino acid analysis. We measure all the 20 essential amino acids plus other amino acids as well. And again, the tandem metabolic screen that sometimes you hear about, it's a machine that looks like this one. And it is one of the also important modalities of diagnosis that is used. These are the basic labs that we order. Most of you are familiar with, blood glucose blood gas, urinary ketones, plasma ammonia, electrolytes, blood count, uric acid sometimes, liver function, lactate and pyruvate, and then we do our own metabolic studies. One slide about newborn screening. Sometimes when you see a child, like let's say about 2 weeks old, presenting in the emergency room, go to the computer and check the newborn screening. You may find the diagnosis there. And we screen for 17 disorders in Saudi Arabia. And sometimes you may find them, whether in your hospital, if he's born in your hospital, or from the Ministry of Health. Now we go to business, how we manage them. First 30 to 60 minutes are very crucial. So remember again that we are dealing with metabolic acidosis and hyperammonemia, and I think you guys know the hypoglycemia very well. So we always want to stop the metabolic decompensation. The whole pathway is blocked. We want to stop this pathway, and the key point is to give high dextrose infusion. When you give high calories, the pathway will not be activated, and this way you can suppress the metabolic decompensation. So high glucose, we mean dextrose 10%. At how much? At 1.5 maintenance. And we tell our fellows, if you have hyperglycemia secondary to this, especially in the ICU, go ahead and use insulin. Don't use less than 10% in a metabolic patient. And then the other electrolytes are the same like any other pediatric patients. Sometimes we deal with, after the hydration, we have to treat the primary problem. So if we deal with a metabolic acidosis, we use liberally the sodium bicarb. We use boluses, we use it in the IV fluid. The only thing that I tell my fellows to watch for is the sodium. If the sodium gives you a room, use sodium bicarb as much as you can to treat the severe acidosis. Because they are producing huge amount of acid, and you have to correct it as soon as possible. In case of organic acidemias, the propionic acidemia, the methylmalonic, we use IV carnitine. The dose is 50 milligram per kg per dose, given every 8 hours for a total of 150 per day. If we are dealing with hyperammonemia, remember, if you have urea cycle, arginine is crucial. And then what we call scavengers, the sodium benzoate, phenyl acetate, phenyl butyrate. If you are dealing with organic acidemia, then carglumic acid will be a better choice. Long-term therapy, which relies on dietary management, on cofactor therapies, high calorie intake, restricting certain amino acid, this is left for us after the emergency room. So I will not spend a lot of time on it. Occasionally, if you are suspecting methylmalonic acidemia, B12 can be an important adjunct to therapy. And if you are dealing with biotinidase, we will come to it. Biotin supplementation will be very crucial. Let's go to the real disorders. So in the emergency room, 80 to 90%, you will face cases of organic acidemias, maple syrup urine disease, urea cycle. If you are not in Saudi Arabia, I will not tell you about this. In the emergency room, you are going to face this no matter what, because we know these are highly prevalent because of the tribal nature, the consanguinity, they are very common. So we will cover these briefly. In some examples, biotinidase is a rare disorder, but it's highly treatable. They come with seizures, especially in the neonatal period. Sometimes they come with vision problems, skin rash, and so on. But the main presentation in the emergency room may be seizures. It has to have, you have to have a high index of suspicion, to be honest with you, and the treatment is biotin. And this is the cycle. I will not spend a lot of time on it, but this is a child presenting with rash, severe napkin rash due to biotinidase deficiency. Homocystinuria, uncommonly to present in the emergency room, except with a stroke, because they have high tendency for thromboembolic phenomenon. And as you know, they have the lens dislocation as part of their disease. Glycogen storage disease, yes, they may present to the emergency room, especially with hypoglycemia. And type 1 is the most common. And it is actually the most common to present with hypoglycemia. So if you are having a child with hepatomegaly, with you know, choppy cheeks and so on, think about this disorder. And the hypoglycemia is very frequent. It's not like one time or two times, it's like almost on daily basis. Pompe disease, another glycogen storage disease, they can present also with cardiomyopathy, hepatomegaly, and hypotonia. Hyperammonemia, this can be challenging in the emergency room. So we will use, as I said in the beginning, we will use high dextrose at a high rate, 1.5 maintenance. We will keep the patient in the first 24 hours MPO. We will stop everything, especially the proteins, and we'll try rapidly to clear the ammonia by giving, as I said, in the urea cycle defect, we give the arginine, and in the organic acidemia, we may use carglumic acid, and then we use the scavengers, the phenyl butyrate or phenyl acetate. If this is not working, or if the patient coming comatose with very high ammonia, let's say more than 500, we immediately will activate the hemodialysis. If you are dealing with a neonate where hemodialysis can be challenging, the peritoneal dialysis will be the choice. These are some of the, this slide shows, you know, infusion of the arginine, the benzoate, the phenyl butyrate, and so on. Let's give some examples now, and I wish we have some interaction, but let me go through this. You are evaluating a neonate in the emergency room who was well until the 3rd day of life, when he started to have poor feeding that progressed to coma, and on examination, he is dehydrated, hypothermic with axial hypotonia, appendicular hypertonia, and you notice limb tremors. As you can see, this is a classical presentation of acute encephalopathy. The details are not so important for you, but this is acute encephalopathy. You're trying to figure out what's the reason. You did some initial labs, and the white blood cell is on the low side, hemoglobin 11.6, platelets 58, sodium 135, chloride 101, potassium 4.5, CO2 7. And we mean by CO2 here is the bicarb. Glucose 1.1. Blood gas, pH 7.12, PCO2 4.3, and bicarb 8.1. Ammonia 278 micromole per liter, and ketones are 3 plus. So when you look at this, clearly you will diagnose a severe metabolic acidosis. And I should say, you know, the audience are from everywhere in the kingdom. What I noticed that the renal profile in the Ministry of Health, they don't provide you with a bicarb. So you have to do a blood gas to see the bicarbonate level. And remember, the bicarb in the renal profile is a measured bicarb. The bicarb in the blood gas is a calculated level. So it's a little bit more accurate to see it in the renal profile if it is available for you. So clearly, this is a severe metabolic acidosis. And there is some hyperammonemia, 278. Remember, ammonia is toxic to the brain. Acidosis is much less in terms of toxicity. So we have to lower ammonia as soon as possible. And so this is the, let's go to some of the questions. The primary problem that we have here is acute encephalopathy triggered by severe metabolic acidosis and hyperammonemia. So back to this slide, we have to measure the anion gap, which is the sodium minus the chloride, the sum of chloride and bicarb. And clearly the anion gap here is very high. The normal is about 6 to 12. So we are dealing with high anion gap, and then you go through the differential of the high anion gap, and then one of the causes will be inborn error of metabolism. Remember, if the anion gap is normal, then the bicarb is lost either in the urine, the renal tubular acidosis, or in the stool. And this is not inborn error of metabolism. Now, so what is the diagnosis? This is a classical case of organic acidemia. Organic acidemia presenting with severe metabolic acidosis and hyperammonemia. The hyperammonemia is secondary to blocking the urea cycle because of the high acid content. And the treatment here, you have to give the high dextrose, that's number one. Give IV carnitine, which is very important for the organic acidemia. Number three, you have to keep the patient MPO. And number four, for this hyperammonemia in particular, if you have carbaglu, with that will be the number one choice. Normally, the ammonia will correct with the hydration and the carnitine, but carbaglu will be of additional benefit. Now let's go to the second case now. A 3-day-old presenting with poor feeding quickly progressed to profound hypotonia and deep coma and collapsed, intubated in the emergency room, and immediately transferred to the NICU. CBC looks okay. Electrolytes, again, bicarb here 22, and blood glucose is normal. Blood gases, there is some kind of alkalosis, 7.5. Ammonia, 1,426. Ketones, 1 plus. So this is clearly a severe hyperammonemia case with encephalopathy, and most likely developed cerebral edema also because of the severity of the hyperammonemia. So here we don't have metabolic acidosis. So this is a urea cycle, classical urea cycle defect. We have 5 or 6 enzymes there. I'm not going to tell you much about, but this is probably the early defect. Usually they present with very high ammonia level. Here again, you do your ABC, the cardiorespiratory support as usual, but here we give the ammonia treatment, the arginine, the IV scavengers, and most likely in this case, we will activate the hemodialysis right away to treat the severity of ammonia. And we will tell the intensive care unit that we are suspecting cerebral edema to take the precaution for high intracranial pressure. And of course, CT scan, emergency CT scan will be also done. So that's the second most common scenario that you will face in the emergency room. The third one, a mother who lost 2 infants with a metabolic disorder delivered a baby 5 days ago. She brought him to the emergency room with lethargy, with an abnormal movements, has opistotonic positioning, and some boxing and pedaling movements, and has an abnormal odor that could be smelled. All labs are normal. This is the trickiest one, and this is what I consider to when I speak to my fellows. I consider them the bomb in the NICU. You send them home, and they come back to you like this. This is maple syrup urine disease. All the labs in maple syrup urine disease, the initial labs are normal. We have to do a tandem or plasma amino acid to diagnose this, which takes about probably 24 hours at least. So we cannot make the diagnosis right away. Most of the cases that come to the emergency room, they are already diagnosed. But occasionally, the first time, we have to wait for probably 24 hours until we get the plasma amino acids. And here you will have the leucine very high, isoleucine, and valine, LIV. The leucine is very toxic to the brain, and that's why they get encephalopathic. Here, the treatment will be again the same way, high dextrose infusion at a high rate. Sometimes we use, if the levels are not too high, we use insulin also to promote anabolism. And many times we will do dialysis because there is no way to clear leucine like the, with any other medication. So this is the second, the third most common that we are covering here. I forgot to say in the first case with the severe metabolic acidosis, you will give the bicarb infusion. We normally add it to the fluid at a 40 milliequivalent per liter if there is a peripheral line. If there is a central, we could go to 60 and 80. And then we give boluses, 1 to 2 per kg, and then repeat the blood gas and push the bicarb. Once we reach around 16, then we are feeling much safer. But be liberal with bicarb, don't worry if the sodium allows you. With this, I think I am done. And thank you very much.
Thank you, Prof. Muhammad, for this great presentation and informative information also. We expect all speakers to move to this stage for part of questions, please. Now the time of the questions for the people is here. Do you have questions?
First of all, thank you for all the panelists, for all the talks. My question for Dr. Al-Haidar, as you mentioned, the diagnosis of bronchiolitis is solely by history and physical examination. However, some viral testing usually mandated by infection control and for isolation. So my question regarding the viral testing, would it impact the outcome of the patient, and are there any clear indication in any scenarios to proceed for a viral testing? And another question for Dr. Fadia. Nurse-made elbow is one of the commonest reasons for our visits in the ER. You mentioned in one of your slides that it can raise a red flag. So can you elaborate and tell us more in which setting or scenario I should be concerned if the baby came with a nurse-made elbow? Thank you.
يعطيك العافية. شكرا دكتور عامل. I agree. The guidelines recommend not to use testing routinely for diagnosis of bronchiolitis. However, I think the infection control implications sometimes requires this. Certainly, if there is resources, it will add value to your infection control data within the institution and even at national level. And also, again, I think the guidelines has to be updated with the changes that evolved even in the pricing and the cost. It used to be costly. Now, I think, again, the pandemic has made it even easier to do testing. We have seen it through drive-through testing for COVID-19. So I think the recommendation might change, taking consideration for the healthcare system, not the patient. So when we say in the guideline, it is not recommended, it's from the perspective of patient care, but not necessarily the healthcare requirement. If there is another recommendation from infection control to study your epidemiology, to know the pandemic nature in your institution, definitely there will be added value. You can study what is the most prominent causative agent. You can know the seasonality, you can know the strains, you can know even if there is implication like the COVID, if it's related to the public health as well. But again, considering the recommendation toward the patient care, it seems the direct benefit to patient care, it does not require identification of the causative agent. So this is how you can handle both what might look contradictory recommendation. Should we do it? It might be yes from the public health policy making, but from the patient care perspective, it shouldn't limit the care because your diagnosis will be dependent on your clinical, as you mentioned.
Thank you, Dr. Sami. Is there any other question? I think Dr. Khattabi.
Okay, thank you, Dr. Amal, for the question. So if you remember the red flags when we talk about, so thinking about the child age and developmental stage. So in non-mobile children, nursemaids will be concerning, kids with disability also. So getting full history, getting the mechanism when it was happened, witness, unwitness, the age and developmental stage of the child, that give you a hint there is red flags in that case. Okay, thank you. Thanks.
Thank you. We have here an online question for Dr. Ismail. In the last version of Nelson textbook, toxic level of paracetamol is 200 milligram per kilogram. But you mentioned 150 milligram per kilogram. Which one we should follow? I told them follow Dr. Ismail. Is that okay? Go ahead, Ismail.
Actually, the American College of Medical Toxicology, they have 150 milligram per kg per day. This is for single dose or within 8 hours. And this would consider as acute ingestion. For chronic ingestion is depend on the durations, like 150 milligram per kg per day only in the first day. And if more than that, 100 milligram per kg per day for 48 hours, 72 hours and more, 75 more than 75 milligram per kg is a toxic dose.
Thank you very much, Dr. Ismail. We have a question for Dr.
Dr. Muhammad, but I've added something about this question because I have toxicologist. This is, I think there is in American, yes, there's 150 milligram per kg. There is also classification. Some of references mention less than 6 years, the toxic dose 200 milligram per kg. More than 6 years, 150 milligram per kg. In the British guys, the toxic dose more than 200 milligram per kg. This is the question. Depend what's the reference.
Okay, thank you very much. For Dr. Haidar, in bronchiolitis, is 90% saturation targeted or more than 92%?
So again, always when we ended up giving a specific recommendation, it's actually a potential inhibition for our instant problem solving skills. So when you say figure, everyone will be looking to the saturation monitor and they will forget the holistic assessment of the patient. So it's very tricky to rely on oxygen saturation because it can vary based on many factors. So if you rely on a reliable check of pulse oximetry, then it goes back to your patient reserve. So if the patient reserve is with bronchopulmonary dysplasia, prematurity, underlying risk factors related to cardiac condition, neuromuscular disease, immune deficiency, then you should accept, you should have higher threshold, and you should target 92 and above. However, if the patient is healthy, 90, actually checking frequently or instantly the saturation is not recommended if the child is out of the high risk group. And if the clinical assessment didn't show significant respiratory distress or high score of clinical severity. So again, it's not about using specific figures. In some of the guidelines, they differentiate between less than 3 months of age, the 12 weeks age group, because they are among the high risk group, or the other, and they have 92 as the target. And for the healthy non-high risk group, 90 as the target. As pulmonologists, we should avoid hyperoxia, not because it is toxic for kids, especially if they are beyond their neonatal period. It's because it can inhibit their central drive. So when they have respiratory insults, we should keep them triggered with the acceptable low level of oxygen saturation. So certainly not to expose them to lower level of saturation, but we should have permissive kind of oxygenation level.
Thank you very much. I have a question for Dr. Fadia. Can we include forensic medicine as part of emergency training? I know this is beyond your specialty, but anyway, because it's deal with child abuse. Maybe also Dr. Sam Al-Haidar, since he is in charge for training in the Saudi Council. Can we include forensic medicine as part of emergency training for the child abuse? So we can have at least the sense of detectivity.
So forensic medicine, part of the training, it's dependent on the location. So in North America, maybe they're not dealing. Middle East and European society, they're forensic medicine, they're part of the front line actually of investigating, detecting those cases. Now they're very precious in our society, so they're dealing also with post-mortem cases. So emergency physician, pediatrician, they can help in diagnosis, but definitely when there is some legal enforcement and there is some medical opinion, expert medical opinion, they've been involved, and it's part of their training here in Saudi. So forensic medicine during the residency, they've been exposed to physical and mainly sexual abuse cases. Yep.
Last question for you, Dr. Fadia. When we should consider cauterization as a physical child abuse, and when should we report this?
Sure. So cultural therapy and cautery marks and cauterizations, it's part of the culture. So education of the society, that's main thing. It's not in the law really listed and said like it's prohibited, and there is a legal consequence for that. But if there is risk of harm after those cauteries, especially with immunocompromised patients, like usually I reported, I escalated even after education. You have to spend time with educating the family. But if they're still keeping doing, and you think the child, you have to balance between the risk of harm and benefit and what were they doing and their culture beliefs. So if there is risk of harm, immediately you need to report that. But it's part of the culture, our culture, like all other different cultures. So you need just to educate the society. Thank you.
I have questions for Prof. Dr. Muhammad about, because more expert in this field in metabolism. I will ask, there is a cure for the child that have error of metabolism. There is some cure, or just extended the suffering of the patient. This is my question. This different between when you start in the King Faisal Special Hospital treating this disease and now, and what's how to cure the patient? Most of the patient can be response to the medication.
So the disorders I gave you, they are considered, they receive partial treatment, so they are considered as chronic patients. There is no cure for them as of today. However, with gene therapies now, there is a gene therapy trial for methylmalonic acidemia now. And I think with this, hopefully, these patients may receive some kind of curative therapies. Biotinidase, on the one I showed you, no, they become normal with treatment. Normal, they go to school, they are fine, everything, unrecognizable to have like a metabolic disease. Tyrosinemia, the one I showed you with liver failure, if he was caught up in the first month of life, he would be a normal child. Yeah. So there are treatable conditions. However, the vast majority, unfortunately, are considered no cure. But we mitigate, the sequelae of the disease.
جزاكم الله خير جميعا. Dr. Sami, regarding the 3%, do you think since there is good evidence it helped in emergency and inpatient, can we send some patient on 3% home as we do with Ventolin and Pulmicort? And my second question for Prof. Urine, I have seen cases of missed metabolic diagnoses. And they were positive in the tandem MS, but no one knows. Either there was some problem in communication with the family. So as pediatrician or emergency physician, is there any website or international or national library I can access or hotline I can contact to know the result of the screening?
So I agree with you. If you go to the adverse occurrence in medicine, communication is the most common type of problem. Yes, we have certain cases where you're absolutely right. Tandem is in the system. Nobody was either notified the caregiver, or the caregiver failed to check on it, or the family was not aware. To be honest with you, the Ministry of Health, they have a national lab, and they also have regional labs, and they have their own communication numbers. I'm not aware of the exact number, but for each region, they have their own way. They always communicate with us. There is a delay for the result to come back when you send it. We know about this. I live at King Faisal, so I have a good access with our metabolic lab. But I agree with you. It's good to know how to reach the newborn screening lab in your region. Normally, the hospitals that are participating in newborn screening, they have a representative within the hospital. So it's good to know the mobile number of that person if you are suspecting a case in the emergency room.
For the hypertonic saline, I think not yet endorsed through the international guideline maker. However, our local guideline that I propose have mentioned it can be. So the level of recommendation has not been yet high. My recommendation is to be used if you are aware of the potential side effect, and if you are aware of what you are using, because the hypertonic saline can vary from hospital to hospital. For example, in our hospital, we have the 7%, not the 3%. And maybe I didn't mention that the hypertonic saline for infant is a strong cough inducer. And some of them, they can go for spasm. So you need to pay attention that you do close observation for the first dose. Don't exceed 3%. And sending this medication to home might be considered if the patient is not among the high-risk group. Because we're still waiting for stronger evidence in use for those particular patients. I think part of the benefit of hypertonic saline is not related to the lower airway effect. I think it has a major contribution to the nasal obstruction, which in my humble opinion has not been addressed in bronchiolitis strongly in the scientific literature. Every interventions has been toward the lower respiratory tract component. And we know in the less than 3-month age group where we see most of the severity in, they are obligate nasal breather. And they're also swallowing and feeding coordination is yet evolving. So I do believe that normal saline and 3%, not beyond that, is effective. However, if you know when and how to observe for their reaction to it, sometimes you need to pre-medicate with beta agonist to prevent the harmful bronchospasm effect. I think it will be. We are just waiting for more evidence to come and also structured interventions rather than the comparisons that I indicated, where I don't think it is fair to compare normal saline in a control arm with 3%.
Last comment from Dr. Mohammed Al-Awain, okay? And then we will have our continue our activity.
Just for the child abuse, يقول الله عز وجل إني وهن العظم مني واشتعل الرأس شيبة. يعني after this, nothing that makes me proud when I think about my career. Looking back, a child was referred to us as a Gaucher disease 12, 14 years ago. And it turned out to be a Munchausen by proxy. The mother used to take the stool, put it in a syringe, and put it in the central line. Multiple episodes of gram-negative sepsis. Finally, there was no support. Dr. Fadia was not there at that time. There was no support. I had to work as a detective. I had to work as confronting the family. And finally, alhamdulillah, we saved the child. She's still coming to the clinic, 16 years old now. But again, this happens everywhere, and you have to have a high index of suspicion. Thank you.
Thank you very much. Indeed, it was very excellent presentation. I really appreciate this. And we are going to distribute the certificate for our excellent speakers, those who didn't attend yesterday. Dr. Amani Kufeidi, please be ready. Take off your mask. No need to wear a mask here. And Dr. Abdullah Al-Hazza, our consultant from Al-Yamama Hospital, he will present the names of the speakers, and they can come on the stage so we can have a nice picture here for each one.
Assalamu alaikum. Just we'll start with Dr. Sami Al-Haider. And we will appreciate Dr. Mohammed Al-Awain. دكتورة فادية خطابي. دكتورة أماني القفيدي. You will not go far, يعني. Staying with us. And big appreciation for tox cases today, Dr. Ismail. and Dr. Abdullah Al-Wadi. And then Professor Bassam bin Abbas. Our moderator for today, Dr. Abdullah Tamimi. And the last one, Dr. Saleh Al-Mania. Thanks for the previous speakers, and we will start our second sessions. Assalamu alaikum. The next speaker, Dr. Amani Al-Gufedi. She's the chairman of Pediatric Hematology and Oncology Department and King Faisal Subspecialties and Hospital and Research Center in Saudi Arabia. Dr. Amani, she will start soon.
Okay, طيب. Assalamu alaikum. Good morning, everyone. It's a pleasure and an honor to be here. Thank you, Dr. Fifi, for inviting me, and I hope, inshallah, ala khair, you guys will benefit. It will not be a complicated presentation, and we're going to... Alhamdulillah. So I heard that there's a huge number of people that are attending online. So what we're going to be talking about today is oncological emergencies. And so I gave you a metaphor here. When you have an emergency such as a head-on collision, you don't really need to be a healthcare provider to know that that's an emergency. You don't need to be a physician or a nurse. I mean, the patient already knows it's an emergency. So when you have a car accident with head-on collision, you've got casualties, you're going to start to think, okay, what are the issues that are going to happen? What are the clinical conditions that the patient may suffer from? Obviously, intracranial hemorrhage. Maybe they've got a neck injury, internal bleeding, external bleeding. Maybe they got a couple of fractures. So that's well and good and fairly easy to understand. The issue with oncology is that you're not sure who's the patient, when is it going to happen, and where is it going to happen, and how. So that's the challenge with oncological emergencies. It might in itself, the clinical condition that happens, it's almost just as bad as if there's a head-on collision. However, how are we going to, as clinicians, figure out if it is, first of all, to recognize it, recognize the potential, because a lot of these things can possibly be preventable, and we need to act fast. And when does it happen? It can happen before the patient is actually diagnosed with having cancer, during the diagnosis, newly diagnosed patients, or patients who have relapse or at the end stage of the disease. So these oncological emergencies can happen anytime before or towards the end of a patient's condition. Now, depending on the clinical condition or depending on the clinical picture the patient has, the oncological emergency could be from the tumor itself, could be from the treatment we have given the patient, or could be due to comorbidities the patient is suffering from during the diagnosis and treatment. And it might not be related to, directly related to the cancer itself. Okay, oh, sorry, I went back. All right, so this slide shows the major oncological emergencies that are seen when we're taking care of patients with cancer. And it is not all inclusive, but however, these are the main things. You've got the hematological emergencies such as hyperleukocytosis, consumptive coagulopathy, hemorrhage, metabolic such as tumor lysis syndrome, hypercalcemia, SIADH, and renal impairment. And then you have the mechanical emergencies that are actually most of the time caused either by the tumor itself or the formation of an abscess or bleeding that can lead to pleural effusion. Cardiac tamponade is another mechanical situation that may occur. Increased intracranial pressure, superior vena cava syndrome, spinal cord compression, acute bile obstruction, intussusception, obstructive uropathy. And there's a various number of infections. These listed here are probably from the commonest. The commonest types of infection for anyone who has received chemotherapy is fever neutropenia. They may develop sepsis, pneumonia, typhlitis, and other various types of infection. So I'm going to mention probably the most commonest oncological emergencies that we see as oncologists, but it's not just oncologists. As I mentioned, these patients may present to you in the emergency room. You may be on call covering internal medicine or covering pediatric, and you get a call from the nursing. These are patients that may be seen in the clinic. We have had patients come in the clinic just on a regular follow-up, and we found out that the child has symptoms and signs that are suggestive of spinal cord compression. So just because a patient is coming to a regular appointment does not mean that the patient may not have an oncological emergency. So again, these patients can be seen anywhere, not necessarily in the cancer, in the oncology setting. And even for us as oncologists, this is most of the oncological emergencies, or a large portion, they happen over time. It does get, so you have to have high alert. You have to have a high suspicion of index. So the first thing I'm going to talk about is tumor lysis syndrome. And tumor lysis syndrome really occurs in tumors or in cancers that have high proliferative rate, usually when there's a large tumor burden. The most commonest cancers that we see tumor lysis syndrome is in acute leukemias, more so in acute lymphoblastic leukemia, but it can be seen in lymphomas, more so in Burkitt's lymphoma. And it results from a massive tumor lysis that releases large portions of potassium and phosphate and uric acid. And the problem with that is that these can form crystals and cause damage to the kidneys. So the definition of tumor lysis syndrome is a patient that has hyperuricemia, hyperkalemia, hyperphosphatemia, and then usually they may have hypocalcemia. It's actually secondary to the binding of phosphate. Now, all these items can cause, and usually do cause, some impairment in the renal status of the patient. So how would we manage these patients? Well, before we go to management, the patient may have the laboratory findings, and for tumor lysis syndrome, there's two types of definitions. One is laboratory tumor lysis syndrome, and one is clinical. If the patient has absolutely no symptoms, but has laboratory findings of tumor lysis syndrome, such as high phosphate, high potassium, high uric acid, then khalas, he's labeled as tumor lysis syndrome. If he has any of the clinical afwan, any of the clinical manifestations listed here, such as nausea, vomiting, diarrhea, they may have flank pain, they have cloudy urine, then they're considered as clinical tumor lysis syndrome. They could have more extensive involvements, and the patient may have arrhythmias and may also suffer from convulsions if there's CNS manifestations. So what do we do? So if you have a patient, for example, that comes to the emergency room with a high, the first thing, he may come with, the flank pain, maybe there's some bleeding, fever. One of the first steps we do actually for probably any patient. And remember, you might not know that the patient has leukemia. You do the counts, there's a high white blood cell count. You suspect maybe the patient has a little bit of lymphadenopathy, hepatosplenomegaly. You get that count, you're starting to think in your mind, maybe this is not an infectious process, maybe this is more serious. So you would look at your renal profile, and you would, you look at your potassium, the phosphate, and this will indicate to you, at least this will alert you. You might not know it's the leukemia right now. You don't have the definitive diagnosis by establishing it, whether through blasts in the peripheral blood or bone marrow, but you would suspect it. So the first things that you want to do is restrict the potassium intake, whether it's oral or when you're setting up your IV. If you've already started your IV fluids, you want to make sure if there was potassium to change that IV fluid. And you want to start to monitor the electrolytes more frequently, especially once these patients are admitted. We tend to do the electrolytes every 6 to 8 hours. And what we do when we first see these patients is that we would start them on allopurinol. And when there's more severe hyperleukocytosis or very high count, we could think of, or the patient has really bad uric acid is very high, we can start thinking about giving rasburcase, but usually the first line of treatment is giving these patients allopurinol. And you would hydrate them. You would want to hydrate them pretty well. The recommendation is to give 3 liters per meter square. However, from experience and from what happens with these kids, you can start with 3 liters per meter square over 24 hours, but these kids really have a tendency to get fluid overload fairly quickly. And so you need to monitor your patients in regards to the vital signs, intake, output, make sure that they're not fluid overloaded, then you need to kind of cut down on the fluids. So the mainstay is to increase the hydration, because that's going to really flush out a lot of these minerals that we see in blood. Alkanization of the urine is something that people used to do in the past. It's no longer, so we don't add, this is probably, I'm sure all of you are beyond that. There's a few of us that still have some gray hair, or that we've developed more gray hair. We used to give sodium bicarbonate IV fluid. That kind of practice has stopped. You would just give either normal saline or D5 normal saline for these patients. So as I mentioned, if a patient with tumor lysis, they may develop hyperkalemia, and hyperkalemia is a serious issue that can affect the kidney and the heart. So you need to restrict potassium, the potassium intake. One of the simplest things to do is give potassium binders. The simplest is Kyaxylate. However, the patients may need to have Lasix. Some of these patients need to actually go, even if we're giving Kyaxylate, the potassium might not go down, and we need to dialyze these patients. And the preferred dialysis for children is CRRT rather than hemodialysis. Another form of treatment of patients that have high potassium is giving them insulin to redistribute the extracellular potassium into intracellular component. Also, beta agonists such as Ventolin has been given to reduce the potassium. So these are the measures that you would do if you have a patient that has already developed tumor lysis syndrome. Now, sometimes you don't have all the features. So we said tumor lysis syndrome, the full laboratory picture is high potassium, high phosphate, and high uric acid. So you might not have all 3 components. And another thing is that your first blood work may be normal, maybe completely normal, the electrolytes. So that's why we monitor it, because we know that maybe in 6 hours, the potassium might start to rise. And then maybe the next day or at midnight, the phosphate starts to rise. So you need to adapt your treatment according to the clinical condition of the patient. And when I say clinical, I also mean laboratory investigations. Okay, so we talked about the fluid, strict intake output, daily weight is important. Oh, I'm sorry, I'm going backwards. All right, now there are some indications in children that have tumor lysis syndrome and even in adults for dialysis. Dialysis is used to prevent irreversible damage of the kidney. And when we decide to do dialysis or the intensivist, we work, when you have a patient with tumor lysis syndrome, really it's a multidisciplinary team. It involves nephrologists, it involves intensive care, and it involves oncologists. So the decision really is made with a multidisciplinary team. And if the patient has features of hyperkalemia, hyperphosphatemia, or very high uric acid that we're not able to control with medications, then we would, then we may need dialysis for the kids. Another metabolic complication that or occurrence that can occur in children with cancer, this is hypercalcemia. But to be honest, hypercalcemia occurs more in adult patients. As you can see here, these we're talking, if you saw the second paragraph, which indicates if these patients that have, you can't see, right. Patients that have bone metastasis, patients have breast cancer, multiple myeloma, head and neck cancers, these patients are more susceptible to develop hypercalcemia, and it's due to increased bone resorption and local bone destruction. And so these are some of the causes. Again, it's not a feature that we see commonly with children, but we do see it. Actually, we did see one case a couple of months ago who had hypercalcemia. That particular patient was a leukemic patient and had been receiving a lot of diuretics. So these are some of the risk factors for a patient to develop hypercalcemia, including immobilization, giving diuretics. And hypercalcemia is not just a thing that can happen in the lab. Patients may have some symptomatology such they don't feel well, they may have nausea and constipation and increased thirst. What do we do with patients that have hypercalcemia? We want to hydrate them well. We want to make sure that they are able to excrete it through the kidneys. We need to give normal saline diuresis. We might give calcitonin biphosphate is another method of treatment. And the most important thing, actually the most important thing for all the oncological emergencies, I would say collectively, is to treat the cancer itself. Syndrome of inappropriate ADH, there's multiple reasons for a person with cancer to develop it. It could be from the cancer itself, especially if we're talking about brain tumors, in particular pineal tumors or craniopharyngiomas. These patients can develop SIADH, but people with cancer can develop a pneumonia, and we know that pneumonia in itself could be a reason for SIADH. And also some of the chemotherapeutic agents that we give to the kids could cause SIADH. From the symptoms that the patient may develop, they may have weakness, fatigability, nausea, vomiting, again, thirst, similar as hypercalcemia. They may have headache and confusion. In the late stages of SIADH, there may be mental status alteration, and they may develop convulsions. As we know, SIADH occurs because of abnormal secretion of antidiuretic hormone. In very simple blood tests, you can find a low sodium. If you find a patient that has hyponatremia, you want to check the serum osmolarity and also check the urine osmolarity and urine sodium. And if the serum sodium is less than 130 and the osmolarity in the blood is less than 280, while the urine sodium is less than 20 and the urine osmolarity is high, this indicates that I'm going to get some water. Sorry about that. Okay. So what's the treatment? Again, treatment of the underlying disease. If the patient has mild to moderate hyponatremia, you want to restrict the fluid. If there's severe hyponatremia, you want to give the patient a slow infusion of 3% hypertonic saline. Now, we'll move into the hematological conditions or hematological emergencies. Mainly, it's patients with high white blood cell count. It can occur with patients with low counts. It's mainly seen in patients with hyperleukocytosis. And we see hyperleukocytosis mainly in acute lymphoblastic leukemia and acute myeloid leukemia, and it's defined. You'll find two definitions. There's some people who define it as more than 50,000. Some books or some papers would say more than 100,000. But any child that has, or any patient that has a white blood cell count of 50 and above would be considered as having hyperleukocytosis. The problem with hyperleukocytosis is that it increases the blood viscosity. And what happens if the leukocytes aggregate and they cause stasis in the blood vessels and the microcirculation. And they do that in the main organs of the body, which is the lungs, the brain, and the kidneys. Now, what are the signs and symptoms? Some patients with hyperleukocytosis may have absolutely no signs, and you find this on the blood test. They're coming in for maybe not feeling well, but there's not really anything specific. But some people may be very sick. They have pulmonary manifestations such as, they have increased respiratory rate, they're hypoxic, and if you do a chest X-ray, they may have infiltrates in the chest X-ray. So these patients are maybe become very critical in a very short period of time. Neurological manifestations that occur in patients with hyperleukocytosis include confusion, lethargy, visual abnormalities can happen. They may have fever or renal dysfunction. So hyperleukocytosis is not just a laboratory diagnosis. However, it could be laboratory, and the patient may have manifestations. It may have serious manifestations. And so these patients are treated very, first of all, they have to be in an environment, hopefully within the hospital. So if in their ER, you have a patient with hyperleukocytosis, again, you would want to hydrate these patients. One thing about patients with hyperleukocytosis who have leukemia, obviously they may have high white blood cell count, but their hemoglobin could be low. And we always get this question, should I transfuse the patient or not? Because we know with the hyperleukocytosis, they already have increased viscosity, so you don't want to add to that. So our recommendation is that patients who have a hemoglobin of 65 and less, then we would transfuse. We would only give 5 mLs per kg and give it as a slow transfusion over 2 to 3 hours, because you don't want that patient to get, the hyperviscosity would increase and they may develop respiratory distress. So again, you have to be very cautious. But if a patient with hyperleukocytosis has a hemoglobin of 70 and generally is in a good condition, I would hold off on giving blood transfusion. And remember, what we say here, maybe there are things that happen in front of us with the patient that makes us change our minds or go in another direction. So you do have to have the whole picture of what's happening in front of you to decide. I don't know how many residents or how many junior staff are with us. My advice is always consult. Don't do something on your own. I mean, even to be honest, I consult people at this stage all the time. Actually, I find that as I get older, I actually, consult even more. So this habit actually is good. When you get other people's opinion, they see something differently. So the golden rule, the older you get, the more questions you ask. So you need to start that from early on. Hyperleukocytosis can lead to ischemia, hemorrhage, and edema of involved organs. And as mentioned, they could have respiratory insufficiency, but they could also have mental status abnormalities, and they could develop stroke. The initial management is similar to what we do with tumor lysis. We would want to hydrate these patients well, aggressive hydration. And I talked about the packed red blood cells. Now, leukapheresis also, this is a management. I told you we stopped giving sodium bicarb with our fluids. We've also shied away from giving leukapheresis because really it just caused rebound of the white blood cells. It hasn't really benefited the patient. There are only a few indications that we might consider leukapheresis, which is a patient that is symptomatic, has pulmonary dysfunction or has CNS dysfunction. In these patients, we would consider leukapheresis. The other hematological or oncological emergency that can occur is DIC, disseminated intravascular coagulation. And what happens with these patients, if they have abnormal coagulation, they can have increased risk of bleeding. So this is considered an emergency. And sometimes these patients may have no symptoms at all. And we do part of the coagulation as part of the blood works. So again, you have to put everything in context. If I have a patient who's febrile, who looks septic, and I do a coagulation profile and it's abnormal, I would go ahead and give fresh frozen plasma because these patients need as much supportive care as possible. However, if I have a patient who is clinically very well and I did the coagulation profile, he doesn't have any evidence, clinical evidence of any type of infection, doesn't have any ecchymosis or bleeding, I might not give it. I would possibly give him vitamin K or her, and then just watch the patient. So again, everything should be taken into context. The common clinical presentation is mucocutaneous hemorrhage, either petechiae or bruises. Patient may have gastrointestinal hemorrhage. Less common presentations is hemothorax, sinus thrombosis, and pulmonary embolism. The laboratory findings for DIC is low platelet count. Usually these patients, and this is a triggering factor. If you have a patient that has low platelets and abnormal coagulation, then most likely the patient has DIC and you would want to treat that patient. So low platelet count, fibrinogen of less than 125, prolonged PT and PTT, and fibrinogen degrading products are high. Treatment, underlying disease. One of the diseases that we see at presentation with a DIC picture is patients with acute promyelocytic leukemia. And so these patients, part of their treatment would be to treat, of course, their underlying disease, but they may need platelet transfusion and fresh frozen plasma.
Ramani,
Yeah.
just 5 minutes left.
شوية زيادة. طيب. Okay, inshallah, it won't take long. So the other thing that I would like to mention is the mechanical. The mechanical complications, it's all listed here, okay? But I will talk about just a couple. The two that I would like to talk about is the superior vena cava syndrome and spinal cord compression. I'm not saying the rest are not important. They're extremely important. But spinal cord compression, especially if we're talking about children, is an emergency. The reason is if we lose the opportunity of more than 24 to 48 hours, if that patient has already lost neurological function, it is extremely, almost 0% that they will regain anything. So one thing for children, is everyone children here? Is the Jamhur children or children and adults?
No, totally adult.
Okay.
Totally adult.
Totally adult? لا في
No.
pediatric and a
Like
pediatric.
all pediatric.
Okay, well, if you get it, all right. So there's a couple of, anyway, remember something. I'm sure you guys know that in the adult world. For pediatrics, it is very rare that children have back pain. So if the child has back pain, you really need to take that seriously, especially if you already know the patient does have cancer. So back pain is a red flag. It's also a red flag for adults, but if it's a regular adult, maybe I won't think of how, back pain is more common in adults. It's obviously more common in females for the multiple things that happens to us. But if you have a cancer patient as an adult who does have back pain, you need to think about spinal cord compression. Again, I'll just go back to the kids. To the kids, really, if you're able to detect it within the first 24 to 48 hours, you initiate treatment, then these kids can regain it. Once about 48 hours, if there's already established spinal cord compression, if the patient already has paralysis, the chances of any recovery, even if you give treatment, is very poor. The other thing اللي كنت أقولها اللهم صل superior vena cava syndrome. I'll tell you something. I'll just tell you a story. Now, this was an inpatient. So remember, you may get this anywhere. It's not just an emergency room. You may get it while you're on call. So we had a child which was 13, 14. So he's kind of at that pediatric adult age. The patient had, and this is important for us here in our society, because that cutoff between the 13, 14 is still not clear. And so we might be taking care of the kids as pediatric, but if something happens to the kid at 14 years, they're going to code patient codes. They're going to call the adult service. So this was the child who was diagnosed as having non-Hodgkin lymphoma, and he was admitted after his chemotherapy with fever neutropenia, and he was getting his antibiotics. But the mother, after he was there for about 12 days, and so the mother was just telling the nurse that she felt his face was a little puffy, and because he's inpatient, our team didn't recognize it. And then the nurse informed the physician a couple of days later that there was an increase of weight. And that still wasn't taken seriously. And because the patient continued to be neutropenic, they decided to do a bone marrow because it was really way far from the original disease, the time the patient received chemotherapy. And so the patient had a bone marrow aspirate under anesthesia with conscious sedation. So we had, thank God there was this anesthesiologist there, and the patient crashed. The patient turned out to have significant lymph nodes and he was an obese kid. So it was it's not, you can't really see it well, but that kid had swelling of his face, had gained in the weight. He coded when he had the anesthesia, and they did the chest x-ray. He also had a mediastinal mass. Alhamdulillah, that kid did well afterwards in regarding to that acute condition. But you can see it became an emergency because the clinicians did not detect it. And that's what's so challenging with oncology patients. It's not like the example I gave you of a head-on car collision when you know it's an emergency. So this is basically if you come out with anything from this lecture, everything that I've mentioned, we all know it. It's just really how to recognize it early, do the preventive measures that are required, that consult every single human being that is possible to help you. The more you consult, you'll get more ideas on what to do. And I'll just show you a picture that I have. And this is actually similar to, believe it or not, this is a picture I got from the net, but I saw that kid, his face looked something like that. And there was another patient that also had swelling of the neck. He didn't have mediastinal mass, but he had stridor. So these patients, in general, patients that do have, increased cervical lymphadenopathy that could be compromising the airway, you want to keep these kids in a prompt position. You want to keep them in a safe and quiet and relaxed environment. Believe it or not, just talking to someone, if any of you have seen patients, or you yourself may suffer from asthma or any other pulmonary issue, once you start not able to breathe, one of the things is just really to calm the patient down. And if they need their family member, it's actually better that they're there. So just being in a quiet environment will help them relax. Let me see, how many more minutes? 2. So these are the symptoms and signs that patients with superior vena cava syndrome may have: cough and dyspnea, dysphagia, wheezing, hoarse voice. If they have stridor, it's more of an emergency than just hoarse voice. Facial edema, they may have headache, they may have mental changes. Just do a plain chest x-ray, a CT scan. And one of the kids, when we did a CT scan, he had extensive. And for the 2 patients that I've seen recently, both of them were obese. And that's sometimes really, and especially when it's just very difficult to examine. So the immediate cares for someone who suspected severe vena cava syndrome include giving oxygen, possibly diuretics, and it's better to admit these patients in the ICU. Okay, so the main thing for patients with suspected superior vena cava syndrome is the first management that I said, which is a supportive care regardless of the diagnosis. If we're able to get a tissue diagnosis, well and fine. As an oncologist, I found it challenging sometimes to get the tissue biopsy. So sometimes when we're stuck, we just go ahead and start steroids, even when we're not sure of the diagnosis. The definitive treatment is chemotherapy. Now, there's a little bit of difference between children with cancer and adult. In the kids, we tend to because the majority of children with cancer in children are chemosensitive. We tend to give, like in cases of increased intracranial pressure or their spinal cord compression, we would just go ahead and start the chemotherapy if we have the diagnosis. In the adult world, surgery is more surgery and radiation. They tend to use surgery and radiation to treat patients, for example, with spinal cord compression, unlike our kids, unlike our patients. So increased intracranial pressure, I won't go. The spinal cord compression I mentioned, which is really an oncological emergency. And I think there was just the last thing I want to talk about is infection. So the infection is considered an oncological emergency because these patients that have cancer, even if they're not neutropenic, they are considered immunocompromised. So if you have a patient that has cancer, even if the counts are good, they can, and especially in children, they're so fragile, you need to treat them with, you need to examine them, you need to do the proper laboratory investigations, and you need to start them on antibiotics. And depending on your institute, because we're not all from the same hospital, and even if we all work in the same hospital, we might be working somewhere else. So we need to follow the guidelines. Like in some hospitals, they would start on tazocine and gentamicin. In other hospitals, they would start on cifepine and gentamicin, or tazocine and epicacine. So really depending on the data from infectious disease or infection control in that institute, you would, so basically what I'm trying to say is that the main thing is that they would need IV antibiotics that cover mainly Pseudomonas and Klebsiella, and then you can add other medications depending on the clinical condition. So any patient that has cancer who has received chemotherapy, you need to treat them as an immunocompromised patient, regardless of their counts, until you establish what way to go. That doesn't mean you cannot stop the antibiotics. You could always stop it. It's, by the way, it's always better to start and then you can stop, rather than not starting and then the patient gets worse. Just a couple of things. Again, I know that not all of you are pediatricians, but for those of you who have seen children can deteriorate very quickly. We had a patient who had the other thing is that children with Down syndrome, or any patient that has any neurological challenge, sometimes the symptoms and the signs are not clear and we miss it. So you need to be careful with these patients who have neurological deficit. They might not complain at all. We had a patient with Down syndrome, and she was actually on antibiotics, and then they stopped antibiotics because her counts improved. And in the morning she had to live, this happened. I'm not making up these stories. So the patient was fine in the morning, but then she had a couple of episodes of vomiting. There wasn't anything else. Within 6 to 7 hours, that patient suddenly became febrile, blood pressure dropped, and we lost that child. She developed septic shock and then finally multi-organ failure and died. So be careful with any cancer patient. It's in that particular, we did the blood culture and then it turned out to be staph. So again, you need to be careful with your patients. It's always better to start something and then you can stop it. And patients with neurological deficit, you really need to be careful because you might miss, they might not show or they're not complain about their condition. So I'm sorry, I kind of quickly went through this. So thank you very much. And if there's any questions, thank you.
I just will leave later,
Okay.
if you allow me.
Bye.
Thanks for you and big home messages. And now I will introduce Dr. and Prof. Bassam. He will just give us the lectures, and his topics today is emergency of endocrine emergencies in children. And تفضل Dr. Bassam.
بسم الله الرحمن الرحيم. First, I would like to thank the organizing committee of the of the 7th International Pediatric Emergency Conference, and I greatly appreciate inviting me to be part of this symposium. In the next 25 minutes or so, I would like to share with you some of the common pediatric endocrine emergencies we are encountering and see in our practice. I will try my best to make it short because I donated some of my time to Dr. Amanda Bifedi as usual. And this is that's why this is the habit of endocrinologists, donating time, donating effort, sometimes donating money for colleagues. So it's not unusual. Thank you very much. So this, a long list of the endocrine problems I would like to share with you. I will go over it very quickly. We have the diabetic ketoacidosis, very well known pediatric endocrine emergencies. Hypoglycemia we are seeing in our clinics, in our practice, because our center at King Faisal Specialist Hospital, we are following a good number of patients with what is called congenital hyperinsulinism, also adrenal insufficiency, hypocalcemia, acute diabetes insipidus, hyperthyroid crisis, and genital ambiguity. So we have a long list of endocrine emergencies we are seeing in our clinics. I don't want to say that the majority of these endocrine problems having also oncology problems as well. As an oncology center, we are seeing these commonly because the majority of our patients having malignancy, they are on chemotherapy, and we are seeing these problems frequently. I will start by diabetic ketoacidosis. As you know, it's a metabolic, well-known metabolic complications of diabetes happening usually in type 1 diabetes, but also it can be seen in type 2 diabetes. I'm saying here that timely diagnosis and comprehensive clinical and biochemical evaluations are the keys for successful resolution and effective management. This is the definition of DKA. It's a triad. It's a biochemical triad of hyperglycemia, ketonemia, and high ion gap metabolic acidosis. Further definition of what we mean by hyperglycemia, a glucose level of 200 milligram per deciliter or more, and acidosis with a pH of 7.3 or less, or bicarbonate level of 15 or less. People also dividing or subdividing diabetic ketoacidosis and its severity into three categories: mild, moderate, and severe. The mild is defined as a pH of 7.3 or less, and bicarbonate level of 15 and less. Moderate, a pH of 7.2 or less, with a bicarbonate level of 10 or less. But the severe one is a pH of 7.1 or less with very low bicarbonate level. This staging of diabetic ketoacidosis is very important when we talk about the requirement and indications of ICU admission. The pathophysiology, I'm sure that all of you are aware about the pathophysiology of this problem. Patients, they have either absolute insulin deficiency or insulin insufficiency with stress and infection. All this can predispose to diabetic ketoacidosis. And if you don't have insulin, or if you have insulin insufficiency, you will have increased lipolysis, increased glycogenolysis, and also you will have increased proteolysis. And all these elements, three elements, will lead to hyperglycemia, dehydrations, and subsequent metabolic problems. So how do we approach diabetic ketoacidosis, which is one of the common endocrine emergencies we are encountering and see in the emergency room? We have to closely monitor the vital signs hourly or even more frequently. We have to closely monitor the neurological signs and symptoms, especially signs and symptoms of cerebral edema, again, hourly or more frequently. Also, we have to monitor the amount of insulin given and also the amount of fluids given. So the input fluid and output are very important to be initiated and documented. The laboratory evaluation, this will include serum glucose, BUN and creatinine, electrolytes, bone profile, including calcium, magnesium, phosphorus, hematocrit, blood gases, and also urine and plus blood ketones.
So you will find different protocols. We have a protocol in our hospital for DKA management. We are using it. Also, we have another protocol for the ICU, but the aim and the goals are the same everywhere. We are trying to correct the dehydration. We are trying to correct the acidosis. We are trying to reverse the ketosis. We are trying to restore the blood glucose to near normal levels. And also during our management, we are trying to avoid the complications of therapy. These are the indications of ICU admissions. If the patient is having severe DKA with a pH of 7.1 or less and bicarbonate level of 5 or less, this is a strong indication of ICU admission. Sometimes we are dealing with moderate diabetic ketoacidosis. So if the patient is young, this is another indication of ICU admission. Or if the BUN is high, or if the patient is hypotensive or having decreased level of consciousness, all these are indications of admission to the ICU. Fluid management is very important. Maybe this is the first step and the cornerstone of DKA management. So we have to document the input and output. We have to assess the degree of dehydration. If the patient is in shock, we have to give him 20 cc per kilogram of normal saline. If the patient is only dehydrated, sometimes we are giving half of that, which is 10 cc per kilogram of normal saline. And all these boluses, by the way, can be repeated as required. The fluid management, I don't want to take much of time talking about the fluid management. It's basically we are giving the deficit plus the maintenance, and the way to correct the deficit and to calculate the deficit, it's well known for all pediatric residents. So a very important point about the fall of the glucose level, we are aiming to improve the glucose level, but we are aiming for a slow reduction of glucose level. So if the glucose reach around 13 or 16, usually we are changing the normal saline to D5. If there is further drop of glucose to lower than 10, we are usually changing the IV from D5 to D10 half normal saline. Regarding the potassium management, you have to look at the DKA child as a potassium depleted child. So if the potassium is very low, we have to add more and more potassium. For example, if the potassium is less than 3.5, we are giving usually or hanging 40 milliequivalent of potassium per liter. If the potassium between 3.5 and 5.5, usually we are giving less potassium. And if the patient is having very high potassium, maybe usually we don't give potassium replacement until further notice. The insulin, the dosages of insulin is well known. We are giving 0.1 unit per kilogram per hour, and our aim to correct the acidosis, and we'll continue usually giving insulin until the bicarb above 15 or 16 or sometimes 17. Cerebral edema over the last 25 years during my practice at King Faisal Specialist Hospital, I didn't see, alhamdulillah, a case of cerebral edema as a complication of fluid therapy in DKA, but this is what is written about the cerebral edema management. No doubt we have to give less fluids. If there are signs of cerebral edema, sometimes we are giving mannitol, and this is the dose, or hypertonic saline, and this is the dose. And here on the right side of the slide, you can see how we are grading or staging the cerebral edema into minor and major criteria. The problem with DKA is not the DKA itself, but sometimes we are seeing complications from therapy like cerebral edema, and we talked about it, or hypokalemia, or acidosis, or hypoglycemia sometimes, or inadequate rehydrations. On the right side of the slide, you can see a long list of complications, including hypocalcemia, hypomagnesemia, hypophosphatemia, alkalosis, a long list you can see of complications associated with DKA management, including pulmonary embolism and including ischemic bowel necrosis. I will move on because of the time limitation to the second topic, which is the hypoglycemia in neonates. And as I told you, in our hospital, it's a referring tertiary care hospital. We are seeing a good number of hyperinsulinism. We are accumulating, by the way, these cases since Dr. Abdullah Rabi'a was in our hospital operating on these neonates. And I still remember the first report on 28 patients with hyperinsulinism had who had pancreatectomy. So we are seeing a good number of these cases, and this is the list of the signs of hypoglycemia, and this is the way we are dividing the signs of hypoglycemia into neurogenic and neuroglycopenic symptoms or signs. The neurogenic, like for example, tachycardia, pallor, hypothermia, and there are some symptoms related to the brain itself, like lethargy, irritability, cyanosis, and sometimes frank convulsion as well. These are the list of the causes of hypoglycemia during the neonatal period, like infant of diabetic mother. This is the commonest, by the way. IUGR, and we have a good number of patients, IUGR with hypoglycemia. And as I told you, sometimes hyperinsulinemia, one of the causes of hypoglycemia. And this is the list: birth asphyxia, prematurity, and other syndromes, including Turner syndrome and Beckwith-Whitman syndrome. This is our approach for hypoglycemia. We are dividing the causes into two main categories: ketotic and non-ketotic hypoglycemia. The ketotic hypoglycemia, this will include, for example, glycogen storage disease, gluconeogenesis disorders. These are the ketotic causes of hypoglycemia. The non-ketotic, as I told you, the hyperinsulinism and fatty acid oxidation defect. The treatment is very simple. It's well known for everyone. If you have a patient with hypoglycemia, our aim to correct hypoglycemia as soon as possible to preserve the CNS function and to prevent further catabolic states. So this is our aim, to correct the hypoglycemia as soon as possible. But this patient, definitely, he will need continuous glucose infusion after bolusing him. If you ask me what the boluses, this is the way we are bolusing our patients. Usually we are giving between 2 to 5 ml of D10 as a bolus for that patient. And again, this should be followed by a continuous glucose infusion. And this is the rate between 6 to 8 milligram per kilogram per minute. Adrenal insufficiency, we are encountering and seeing a good number of patients with adrenal insufficiency. And in our hospital, we are following maybe the largest series of patients with congenital adrenal hyperplasia and also the autoimmune polyglandular syndrome or disease. We have the long list of the genetic causes of adrenal insufficiency. So we have the primary ones and we have the secondary ones, secondary to sepsis, to infiltration, secondary to drugs. But the genetic causes of adrenal insufficiency is very common in our center. It could be secondary, not in the adrenal, but in the pituitary gland or in the hypothalamus, caused by tumors or caused by surgery or caused by irradiation. These are the features or the signs of adrenal insufficiency: anorexia, apathy, confusion, dehydration, fatigability, hyperkalemia, hypoglycemia, hyponatremia. I'm sure that you are aware about the signs and the biochemical findings of adrenal insufficiency. And that's what we are doing with our kids with adrenal insufficiency. Usually we are asking them to have a report from our side. We don't have the alert like in the West. I wish we have it, but we don't have it. But we usually are providing them with a card and with a report and with injection kit, which is solimedrol or hydrocortisone. And we are asking people, our teaching patients and parents, and we are writing that in the report. If you have a problem like fever or stress, you have to double the dose of hydrocortisone or even triple it. But if you are not able to keep it down and you are vomiting, so in this case, you need to go to the ER to get a hydrocortisone bolus emergency. And this is the dosages. It's based on the meter square, but there is a very simple way of figuring it out. For example, for young children, we are giving 25 milligram. Those who are between the age of 3 and 12, we are giving 50. For older children, we are giving 100 milligram as a bolus of hydrocortisone. Hypocalcemia, again, we are seeing a good number of patients with hypocalcemia in our center because we are following, again, the largest series of genetic rickets in our hospital. And these are the symptoms and the signs of hypocalcemia, like irritability, paresthesia, tetany, spasm, sometimes frank convulsion. If you ask me about the signs, this is the two signs you can see in patients with hypocalcemia. Okay, the causes, there are maternal causes and there are neonatal causes. Maternal causes, diabetes or toxemia of pregnancy is the commonest cause of hypocalcemia, plus vitamin D deficiency. And the neonatal disorders like being low for gestational age or having asphyxia or sepsis or renal impairment or using anticonvulsant treatment. These are the contributing factors of low calcium. There are two main categories of hypoparathyroidism. In our hospital, we are following a good number of hypoparathyroidism, again, congenital ones and also the acquired ones. And I'm sure that anyone trained at King Faisal Specialist Hospital, he should know by heart Sanjay-Sakati syndrome, which is the commonest cause of congenital hypoparathyroidism and the commonest visitor to our emergency room with hypocalcemia, hyperphosphatemia. But also we are seeing acquired causes of hypoparathyroidism, like the autoimmune polyglandular syndrome or disease. And there are other causes like surgery, radiation, destruction, infiltration, inflammation, a long list of causes of hypoparathyroidism. Vitamin D deficiency and disorders, again, we published recently over the last 2 or 3 years, the largest series of patients with 25 hydroxylase deficiency, the genetic 25 hydroxylase deficiency, the 1-alpha hydroxylase deficiency, and we are still following the largest group of patients with vitamin D resistant rickets due to vitamin D receptor defects. And also we are having more than 80 plus cases of X-linked hypophosphatemic rickets caused by fixed mutation. So the majority of these patients, they will come to the DMU, but sometimes if things went wrong, they will come to the emergency room. The hypocalcemia management, this is the normal levels for total and ionized calcium. But generally speaking, if you have a child with hypocalcemia, we are giving calcium gluconate 10% between 2 to 5 ml per kilogram as a bolus for that patient. This is like a standard of care. Any patients requiring calcium infusion, you have to put for him a large IV line, trying to avoid any infiltrations, trying to avoid any bad effect on the skin. DI, Dr. Amani, we should talk about the DI and SIDH again, because we are an oncology center. We are seeing a good number of diabetes insipidus, and this is the main causes of hypernatremia. It could be low volume or normal volume hypernatremia. The low volume, like diabetes insipidus, like dehydration, like any fluid losses from the GI, like gastroenteritis, from kidneys, from skin, like burns, and normal volumic or high volumic hypernatremia because of the increased intake or overfeeding of these infants with concentrated formula or infusion of hypertonic solutions. These are the causes of DI. We have the central, we have the peripheral, and we have the acquired and the congenital causes of central, and also the nephrogenic DI. The treatment, usually we don't use, after diagnosing a patient with DI, usually we are not using the IV vasopressin. It's available in our hospital. We rarely use it. Usually we're using the oral forms or the nasal form of vasopressin or desmopressin. And this is the preparations we have in our hospital. We have the vasopressin, we have the desmopressin, we have the nasal solution, we have the sublingual preparations. All these preparations are, we have it in our hospital. And if we diagnose somebody with DI, usually we are replacing him with the fluid plus giving him the appropriate dosages of desmopressin. Hyperthyroidism, by the way, hyperthyroidism in general is not common in pediatrics, and I didn't see a case of hyperthyroidism in my life, but the features or the symptoms and the signs, like difficulty in gaining weight, like a tachycardia, like frequent bowel motion, being warm, having moist skin, nervous, all these signs of the hypermetabolism. The treatment, the first treatment is the antithyroid medications like PTU, like methimazole. I prefer usually PTU in case of thyroid storm, because PTU not only affecting the enzyme, which is the peroxidase, but also inhibiting converting T4 to T3 as well. So we are using the antithyroid medications to prevent the iodination, but at the same time, sometimes you have to use what is called the iodide, like the saturated solution of potassium iodide. These preparations helping us to prevent release of the preformed thyroid hormones. Beta blockers is very important to use because of the cardiac manifestation of Graves' disease or hyperthyroidism from one side, and from the other side, the beta blockers inhibiting conversion of T4 to T3. Steroid therapy also, it can be used, and it's very helpful in inhibiting T4 to T3 conversion. Ambiguous genitalia, when we talk about endocrine emergencies, I'm sure that the majority of us, I mean, the endocrinologists will not list genital ambiguity, but it's really, it's a social emergency and it is a medical emergency. And the reason I brought it up here, because maybe this is the more common than diabetic ketoacidosis. You know, our center is not a diabetes center, unfortunately, but we are seeing a large number of cases with genital ambiguity. So it's a social emergency because you have to find out this is a boy or a girl. I mean, the mother is pregnant for 9 months, the father is waiting, the mother is, the parents, the whole family is waiting outside, trying to figure out this is a boy or a girl. So it's really social emergency. And this is the way to figure it out. This is a boy or a girl by doing the 3 things. And this is what we are teaching our trainees for years now, how to figure out this is a boy or a girl. We are depending by the law on the appearance of the external genitalia. If the external genitalia is ambiguous, it's not clear, you cannot tell this is a boy or a girl. So how can you figure it out? By doing 3 things. Palpate for the gonads. If you feel something, this is testis, most likely testis, and you are dealing with a boy. Do ultrasound, call the radiologist. He will do immediately ultrasound for you, looking for the gonads, and at the same time, he will look for the uterus. And what's good about King Faisal that we can do the chromosomal analysis within 3 days, and we can do FISH within 6 hours. So there are 2 possibilities. If there is gonads in your uterus, XY, you are dealing with a boy who is under-virilized, having less androgens. If we are, the opposite is true. If you cannot feel gonads and you cannot see gonads by ultrasound, and if the karyotyping is XX, most likely you are dealing with an over-virilized female, which means a female exposed to high androgens. This is the social emergency. So the social emergency can be solved quickly within few hours, and you can go out to the mother and to the father, to the parents, and say, okay, you have a boy or you have a girl. The problem is not restricted and limited to the social emergency. It might be associated with medical emergency, with electrolyte imbalance, hyponatremia, and hyperkalemia because of the adrenal problems and because of the aldosterone cortisol deficiency. So you might be dealing with an under-virilized male with salt wasting, or sometimes non-salt wasting. If it's non-salt wasting, so there is no medical emergency, alhamdulillah. But if it's salt wasting with hyponatremia, hyperkalemia, you have to deal with this medical emergency. And the same thing applies to the over-virilized female. She might be associated, I mean, the problems might be associated with the salt wasting and sometimes is not associated with salt wasting. This is the list of the causes of genital ambiguity. It's very easy to remember, like, for example, salt wasting, star deficiency, beta-hydroxysteroid deficiency, and a lot of enzymes deficiency, but the commonest is 21-hydroxylase deficiency. I have to stop here, and because of the time limitation, and the floor is open for discussion.
Thank you, Prof. Bassam. So the next speaker for today, Dr. Ilham Al-Qahtani. She will present for us ocular emergencies in children. تفضلي دكتورة.
ما امسك هذا الشيء. هنا البوينتر هذا. البوينتر تطلع هذه ولا على الشاشة؟ اوكي. ما ينضغط سوا. ما ينضغط كيف ثاني. Assalamu alaikum. Good morning, everyone. Thank you for this opportunity to share with you the most common ocular emergencies in children. Today we'll discuss quickly the normal eye anatomy and the important component of the eye exam, and we'll recognize the important ocular emergencies with their initial management. As you know, with increasing medical complexity, the most physicians' width of knowledge has decreased because the depth of knowledge has increased. Always remember, outside of your area of expertise, it's very important to know just the basic or small knowledge. If you have a plan, if you have a plan to be able to check a vision, and always don't be afraid to look at the eye and know the basic about common and visually threatening eye disease. Any condition that's associated with vision loss or can cause vision loss or structural damage, as well as pain, is considered as emergency case. There are three most common presentation in emergency department. You can see the vision loss, trauma, and red eye. So always ask questions in details about the vision loss. Is it real loss or just a blurry vision, unilateral or bilateral, if it's transient or permanent, the onset of the vision loss and associated with pain, discharge, or a history of a trauma, any medical history of diabetes, if there is any history of contact lens wearing. The most important component of the eye exam is the visual acuity. The visual acuity is considered as the vital sign for the eye. Secondly, to examine the external eye examination by the slit lamp examination. Quickly, I will review with you the normal anatomy of the eye. As you know, the normal eye starts with the normal eyelid, then the white transparent conjunctiva with underneath it white sclera, and clear transparent cornea with anterior chamber, which is the depth between cornea and the iris, with the normal crypt of the iris, and the pupil should be round, regular, reactive, and the eye filled with a clear vitreous gel. The normal fundus should appear like this, with the normal retinal blood vessel and healthy clear margin of optic disc, shiny macula. Now we'll start a few important cases you can face in emergency. So for example, if you receive a patient with history of the trauma by her cousin in her eye, she came with history of pain and redness and tearing. When you examine the patient, you find this picture. So as you see here, there is central corneal abrasion, which takes stains of fluorescent. Corneal abrasion is more common after any trauma, and you will see it in emergency department. How can you manage it as emergency physician? You have to start by applying topical anesthesia like propcaine or tetracaine, so to help the patient to open his eye. Then examine the cornea by using fluorescent. If there is only corneal abrasion, just give the patient topical antibiotic. Always avoid eye patching in children. A second example of the eye trauma, if the patient came with history of playing in garage with his dad, and his dad, while he was drilling, then he felt something struck in his eye. When you see the eye, you find there is a foreign body in the conjunctiva and foreign body in the cornea. So usually this is present with similar symptoms of corneal abrasion. It's very important to avert the eyelid to rule out any foreign body by using a Q-tip. If the foreign body is superficial, you can remove it just by Q-tip. If it's deep, better to refer the patient to ophthalmology to remove it by using a sterile needle. Another example of patients present in the emergency after a fight with a knife, and he came holding his eye in pain. When you examine the patient, you find this. There is oblique laceration extend from sclera to cornea. So this is corneoscleral laceration, which is usually happened after penetrating or blunt trauma and required surgical repair by ophthalmology. As emergency department, you have just apply clear shield, keep MPO, avoid using any drops to prevent any tissue prolapse, and consider tetanus prophylaxis according to the kind of injury, and consider orbital CT scan if you felt there is foreign body inside the eye. Another example, if you have a 5-year-old child fell and hit his face on a metal object and cut his eyelid. On examination, you see there is eyelid laceration on the nasal 1/3 of the eye. It's very important in the emergency department to be sure the globe is intact. If you see the eyelid laceration superficial, it can be closed by wound closure, but when you will consult the ophthalmology, if it's involved the medial 1/3, because you are worried about canalicular injury, or if it's involved the lid margin, because tarsal plate or levator muscle. This is another example of lid laceration secondary to the dog bite. You will see there is a tissue loss, and it's involving the lid margin with tarsal plate and the lower lid very close to the canalicular system. So this patient needs to be referred urgently to ophthalmology for repair. Don't forget, because it is a dog bite, to consider rabies prophylaxis. Always, any eyelid laceration, look for injury to the globe. Another example of a patient was playing with baseball, and he had a trauma by the baseball and presented with severe pain. You saw the CT scan before entering the room, and you find this. There is the orbital floor fracture with globe rupture. So how do you know there is a globe rupture? Because the pupil is displaced nasally. The mechanism of injury usually occur with the blunt or penetrating injury, and sometimes the globe rupture is not obvious. It's subtle, especially if it is posteriorly. The important sign for globe rupture is peaked pupil and sidal test. Sidal test, by using fluorescent, you will see like a leak. So in emergency, it's very important, the goal to prevent increased intraocular pressure. So just apply the clear shield and give the patient antiemetic, start MPO, tetanus prophylaxis, start a systemic antibiotic, then immediate consult the ophthalmology. If you have such patients who present with a history of double vision and he is unable to move the eye upward, by examination, you will see his eye can't pass the midline here. So what you are suspicious of? The orbital floor fracture with entrapment of the inferior rectus. So a blowout fracture, it's very common because the maxillary roof, it's very weak. So it's easily fractured in blunted force. So the symptoms of the blowout fracture, eyelid swelling and ecchymosis, enophthalmos or sinking in the eye, ptosis, double vision, anesthesia of the upper cheek. In the orbital fracture, it's very important to do orbital CT scan. If you don't have orbital CT scan, the plain film may be helpful. So the management of any orbital fracture, consider as usual the tetanus prophylaxis. Here, surgery is not always indicated, so it's not urgent to refer the patient immediately to the ophthalmology, because if there is surgery, it will be not indicated before 7 to 14 days. Always tell the patient to avoid blowing their nose. Another scenario of a 3-year-old girl who was hit in her eye by a toy truck. Then on examination, you find this. The blood in her anterior chamber. This is what we call it hyphema. So the hyphema is secondary to the iris bleeding and usually a result of a blunt trauma. The significant risk of secondary bleeding will occur in 2 or 3 days after trauma with poor outcome. So in emergency department, it's important to apply the clear shield, ask the patient for bed rest with head elevated 30 to 45 degree, and stop any anticoagulation like aspirin and refer to ophthalmologist. Sometimes the patient need admission. Please don't confuse hyphema with subconjunctival hemorrhage. This is the subconjunctival hemorrhage. We'll see it's localized temporally. And in this case, subconjunctival hemorrhage generalized. So subconjunctival hemorrhage, it could be spontaneous or secondary to a trauma. If it's spontaneous, it is self-limiting. If it's secondary to the trauma, it's important to refer the patient to ophthalmology to do eye examination. Another scenario of 5-year-old boy present with a red, painful upper eyelid started in the morning when he woke up. On examination, you will see here a swelling of upper and lower eyelid with erythematous changes. So this is the periorbital cellulitis. As you know, it is a major ophthalmological emergency, and it is potentially life-threatening. It may occur after trauma or after insect bite, sometimes associated with sinusitis. The common organism are pneumococcal, staphylococcal, and streptococcal. In preorbital cellulitis, it's very important to assess the visual acuity and the extraocular movement and the pupil to rule out orbital cellulitis, as well as to check the temperature of the patient. If you doubt there is orbital cellulitis, it's very important to do CT scan and blood culture. So if it's only preseptal cellulitis, you can ask the patient for bed rest and systemic antibiotic, refer the patient to ophthalmology. But if it is orbital cellulitis, it needs urgent ophthalmological referral. What are the signs of the orbital cellulitis? Proptosis, chemosis, decreased motility, and decreased vision with apparent Urea defect. And urgent CT scan is very important. Now we'll quickly cover the most common ocular symptoms and signs you might face in emergency. Red eye, the most common, there is a long list of red eye differential diagnosis, but I will go through the most important one, which is conjunctivitis. It's very important when you have conjunctivitis to know what is the underlying cause. If you think it is bacterial conjunctivitis, the patient will present with yellowish greenish discharge. So it's important to take conjunctival swab and start topical antibiotic drops. If you think this is allergic conjunctivitis, patients usually complain of itchiness. Then on examination, you will find papillary reaction, or what we call a giant cell, a giant papillae. So start the patient with cold compresses, mast cell stabilizer, and antihistamine. If the patient had a history of upper respiratory tract infection, then present with injection in one eye, after a few days transfer to the other eye with watery discharge, then think about viral conjunctivitis, which is treated conservatively by lubrication and cold compression. If there is a history of blepharitis, then injection of the eye. Sometimes it's blepharoconjunctivitis. It needs lid hygiene and topical anti-inflammatory or antibiotic. The emergency in the eye is a chemical injury. So the chemical injury, it needs immediate irrigation for 30 minutes before starting the history or examination, until neutralization of the pH of the eye, because it might damage the limbal cell, would cause severe scarring and severe vision loss. After copious irrigation for 30 minutes, then see the depth and extent of the injury and refer the patient to ophthalmology. It's important to refer the patient to ophthalmology because it might need corneal or limbal cell transplantation. This is another case of a patient present in emergency room with sudden proptosis after blunt trauma. As you see, there is axial proptosis. It's very important in such case to rule out retrobulbar hemorrhage because it might cause vision loss secondary to the retinal vessel occlusion, and it needs immediate ophthalmology referral, and the patients need to be on IV mannitol to decrease intraocular pressure, IV steroid, as well as lateral camphotomy as soon as possible. Sometimes in the emergency, you will see some parents brought their kids with different complaint like severe sudden acquired strabismus, either inward deviation or head tilt, or unable to close their eye. In such cases, you have to think about cranial nerve paresis. Such patient needs urgent imaging to rule out a space-occupying lesion. Red reflex is very important to know how to examine even in uncooperative children because it will rule out the most important differential diagnosis of leukocoria. As you know, leukocoria, it is a white pupil. And it's very important to test the red reflex to rule out retinoblastoma. As you know, it is life-threatening. The other causes of leukocoria, congenital cataract, cod disease, vitreous hemorrhage, PHPV, and optic disc coloboma, toxocara. So in summary, As you know, the ocular injury is the leading cause of preventable vision loss and blindness. Over 90% can be prevented with education and safety goggles. It's very important, if you are in doubt, always refer the patient to ophthalmology. Thank you.
Thank you, Dr. Ilham, for informative lectures. But at the end, we will consult you actually. So now, Dr. Abdullah Al-Wadi, cardiac emergency consultant, and he will present for us cardiac emergency in children. Actually, Dr. Abdullah is a consultant and intensivist in Prince Sultan Hospital and Riyadh in Saudi Arabia.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Thanks for staying late. I really appreciate. I will not talk for 30 minutes because I don't think I can handle myself even talking for 30 minutes. So we'll try to make it shorter than 30 minutes. So the cardiac emergency in the pediatric emergency departments is mainly structural problems. As you can see, the heart structure, when it's normal, it's like this. There is no connection between the four chambers, and the blood on the right side is blue, going to the lung and coming back to the left side with a good amount of oxygen. We call it red blood or oxygenated blood. And most of the patients who have cardiac problem will come to the emergency room visit because of cardiac symptoms. The most common cause is a high QB/QS. QB is the amount of blood that goes to the lung or pulmonary circulation, and the QS is the amount of blood that goes to the systemic circulation. And there is high QB/QS, which means blood going from the left side to the right side. It makes the lung is congested, and they will have congestive heart failure. This is common in a shunt lesion like ventricular receptor defect, VSD, and ASD, and PDA, and other left to right shunt lesion. Like this one, this is an AVSD with a lot of shunt to the lung, and those patients will present with lung congestion and symptoms of heart failure. And that's the X-ray that usually you see in the ER, big heart and fluid in the lung. On the other side, there are babies who have right to left shunt, or what we call a low QB/QS, and the patient are cyanotic. We call them in the past blue babies. Like the most common example is the tetralogy of Fallot, where you can see in this diagram that the blood is going from the blue side of the heart, which is the right side, to the left side. So the baby will have low oxygen saturation. He will be blue, but he will not have heart failure symptoms. And if you do an X-ray in the emergency department, you will see something like this, what we call a boot-shaped heart. The heart size is small, and the lung field are oligemic, so there is no much of a blood flowing to the lung. The third category of structural abnormalities that might visit an ER is a patient with systemic cardiac output limiting lesions. So the blood is not going to be able to come out from the heart to the systemic circulation. The patient will have a cardiac output problem, and they might present with shock, low blood pressure, and metabolic acidosis. That was a coarctation. This guy is the extreme of that category, where the left side of the heart is not formed, what we call hypoplastic left heart syndrome. There is no mitral valve, no aortic valve, and no LV adequate size. So the patient will depend on the blood coming from the right side through patent ductus arteriosus. Same thing can happen when the right side of the heart is small. We call it hypoplastic right heart syndrome. Sometimes call it a tricuspid atresia, but also they can present with low cardiac output if the ductus has closed. You might see in the ER a patient who come to you with any symptoms after cardiac surgery, either cardiac related or non-cardiac related. This is example of patient with abnormal heart structure, congenital heart disease in the form of tricuspid atresia and pulmonary atresia and small right ventricle. These patients, we help them by giving them a shunt between a systemic and pulmonary artery to maintain their blood flow to the lung. So if they come to you, this is a stage 1 of single ventricle palliation. This is called a Blalock-Toxic shunt and now they call it sometimes central shunt if it's between the aorta and the pulmonary artery. But remember, these patients or those patients is saturation is normally above 70. So don't worry if their saturation is 70 and above. That's their normal. The extreme form of this surgery that we do on cardiac surface is the Norwood procedure, which is a surgery for the hypoplastic left heart syndrome, where we augment the aortic arch using the pulmonary artery and establish the BT shunt between the pulmonary and the systemic artery. Those patients also remember, please, their saturation normally is around 70 to 80. So if they come to you with any symptoms, saturation is in the 70s, don't panic, this is their normal. After the second stage, what we call it the Glenn shunt, their saturation improved to above 75 usually, down up to 85, sometimes 90. And the Glenn shunt is a connection between superior vena cava, which is number 3 here, and the pulmonary artery. So all the blood that comes from the head and the arm goes to the lung directly without passing through the heart. Again, their saturation is above 75. There is no acidosis. Don't worry about them. The last stage of the single ventricle palliation is the Fontan circulation. As you can see, there is no fenestration between the conduit that connect the IVC to the pulmonary artery. Their saturation usually is above 90%, unless there is a fenestration we created in the surgery between the right atrium or the conduit to the heart itself. Those patients might have a saturation of 80 and above. So in single ventricle physiology, you need to know what stage they are on so you can accept a certain level of saturation for those patients. So it is a bit confusing. So let us wrap it up in this table. So the emergency presentation of heart disease, on the left side column, you can see the symptoms. It could be respiratory distress. And they can present with tachypnea, retractions, wheezing, and grunting. And the pathophysiology for that is a lung compliance that's decreased, metabolic acidosis, and respiratory alkalosis. And they are usually having pulmonary edema, airway obstruction, and anxiety, and parareceptor stimulation that can cause cough. The other presentation is a shock, cardiogenic shock, where they are tachycardic, poor perfusion, hypotensive. They have decreased cardiac output, and that's because of obstructed lesion, decreased contractility, and increased afterload, like in the case of coarctation. The third presentation is cyanosis. So it can be central cyanosis, specifically for cardiac lesion. They are hypoxic and hypoxemic at the same time, and they have right to left shunt, yet they don't have signs, most of the time, they don't have signs and symptoms of heart failure, but they are low saturation. For cardiogenic presentation specifically, there are a few pitfalls I would like to draw your attention to, is that the most presentation with respiratory distress, metabolic acidosis, stimulation of baroreceptors, and it can be misdiagnosed as asthma or bronchiolitis or pneumonia. And I will show you later on that a lot of patients have been missed after 3 visits from the ER, with heart failure. Early manifestation of pulmonary edema can be wheezing and hyperinflation, and the treatment of bronchodilators can worsen the situation. An apparent dehydration that usually they present with can lead to inappropriate fluid expansion, which might not be tolerated by cardiac patients. And lack of obvious findings such as jugular vein distension, which is common in an adult, or hepatomegaly is not present in pediatric patients. So it makes it difficult for you, ER physician, to diagnose heart failure in pediatric patients. The shock state is often blamed on sepsis in most of the case, because sepsis is much more common than cardiogenic shock. Metabolic acidosis is also blamed on hypovolemia, which is most common presentation of hypovolemia, shock and metabolic acidosis in pediatric patients. And lack of cardiomegaly in X-ray is an early stage of myocarditis. All of these make it difficult for you guys in the emergency to diagnose cardiogenic shock easily. What is the risk of commonly employed treatment that you guys might use in the ER, and it might harm the pediatric patient with cardiac problem? Oxygen, for example, is a commonly used drug or medication in the ER, and it causes pulmonary vasodilator. It can worsen the pulmonary edema. It can cause pulmonary circulation steal in single ventricle situation, and it causes peripheral vasoconstriction and increase afterload. Fluid bolus, commonly used in pediatric ER. It can worsen the pulmonary edema, decrease coronary perfusion. Albuterol or Ventolin, very commonly used in ER, and it can increase the metabolic demand and consumption of oxygen by myocardial muscle, and it can worsen the tachypnea and tachycardia and cause more metabolic acidosis in patients with heart failure. Furosemide, although it's indicated in many cases of cardiac patients, but it can worsen relative hypovolemia in those patients if you don't know their exact anatomy. Bronchodilator, as we can say, as we said before, it can worsen the clinical state of the patients, and apparent dehydration lead to inappropriate fluid expansion in patient who has cardiogenic shock. So how do we categorize those type of patients? So cardiac patient presented to the ER can be categorized based on their age of presentation, saturation level, and response to treatment. So let's talk about age of presentation. Neonatal presentation with cardiac problem is usually serious. Sometimes they are crashing. However, above neonatal period, above 1 month, they are usually not crashing, not very sick, but they can present at any age, which can be also serious or and crashing, or can be mild as well. So neonatal presentation with cardiogenic cardiac problem, most of those patients are duct-dependent lesions. They have limited blood flow to the lung, like pulmonary atresia, critical pulmonary stenosis, severe tetralogy of Fallot. They have low saturation. They have reasonable cardiac output, if the duct is still open to some degree, and they have normal blood gases. The only problem with them is low saturation and cyanosis. The other category is limited systemic blood flow with normal saturation, but they are usually presented with cardiogenic shock, like the case of critical aortic stenosis, coarctation, interrupted arch. Usually saturation is okay, but they have decreased cardiac output. The other category is limited systemic blood flow with low saturation, like hypoplastic left heart syndrome, critical aortic stenosis. The other category of neonatal presentation is not duct-dependent lesion, like total anomalous pulmonary venous drainage with obstruction, cardiomyopathy, or arrhythmia. Infantile presentation of cardiac disease, the most common is left-right shunt lesion with congestive heart failure, like VSD, AST, PDA. Left-to-right shunt lesion with cyanosis, like with no heart failure, like tetralogy of Fallot, single ventricle with unrestricted blood flow to the lung. Non-critical valvular lesion, like severe PS, severe AS, or mitral regurgitation. Cardiomyopathy, either primary or secondary, like in the case of Alcaba syndrome. If they are more than 1 year of age, the small left-right shunt can present at that time. They can have arrhythmia, cardiomyopathy, infection, inflammation, or other causes. We can also categorize cardiac patient based on the saturation. So if they are not cyanotic, their saturation is normal, above 95, with pure left-to-right shunt, like PST and AST, or no shunt, like cardiomyopathy or coarctation. This is one presentation. So they have no cyanosis, but they can be on heart failure. They have cyanosis, where saturation is above 70 to 80. They can, but remember, their blood gas is normal if the cardiac output is maintained, which is common in those type of patients. They have pure right to left shunt, like tetralogy and pulmonary atresia, or TGA. Mixing lesion, like AVSD or total anomalous pulmonary venous drainage, or truncus arteriosus type of patient, they might have a saturation between 80 and 95. The rare, but sometimes you can find it, what we call differential cyanosis and interrupted aortic arch, where the saturation in the upper limb, upper part of the body is more than the saturation in the lower part of the body. If we categorize them based on the response to therapy, which is very important for you guys in the ER, if they improve with oxygen, that means they have cyanotic heart disease, or they have heart failure with no shunt, like a cardiomyopathy. If they deteriorate with oxygen, that means they have left to right shunt with pulmonary edema, like patient with VSD, or PT shunt with a stealing phenomena, or they have duct-dependent lesion, as they might have their duct closed. If they improve with prostaglandin, they are duct-dependent lesions. If they deteriorate with prostaglandin, they might have obstructed total anomalous pulmonary venous drainage. And this table might help you to figure it out. So if they're cyanotic with increased pulmonary vascularity, it's either truncus, arteriosus, total anomalous pulmonary venous drainage, or transposition of great arteries. So those patients are blue, but they don't have pulmonary edema. If they are blue, cyanosed with decreased pulmonary vascularity, like tetralogy of Fallot, Obstein anomaly, or tricuspid atresia. If they are not cyanosed, but they have congestion in the lung, they are VSD, AST, or PDA. If they are not cyanosed, but they have normal vascularity, they are either aortic coarctation, mild form of it, or aortic stenosis, or pulmonary stenosis. So what we learned so far, remember that neonatal presentation of cardiac diseases should be taken very serious in the ER. Prostaglandin should be started as soon as possible when suspecting a congenital heart disease in a neonate. Any saturation above 70 with good gases and hemodynamically is acceptable. In fact, oxygen may harm certain cases, but please call cardiology to confirm your suspected diagnosis of cyanotic congenital heart disease. We cannot leave this topic without talking about heart failure, because it's one of the most common presentation to the ER for pediatric patients. And unlike the adult, in pediatric, we don't have a common language. So if somebody call you from other cities and he's telling you about heart failure patient, in the adult, they use New York Heart Association category. So he can tell you that he's New York Heart status 1 or 2 or 3, then the adult cardiology will know. In pediatric, unfortunately, we don't use it, although we have something like New York Heart Association classification, which is ROS classification, which is more or less the same. No symptoms is class 1, mild symptom class 2, moderate symptoms class 3, and severe symptoms at risk class 4. So please start to use this one. So when you call somebody for a patient with heart failure, you can use this classification. It's called ROS or revised ROS classification. In ER, please keep in mind that congestive heart failure can mimic respiratory diseases all across the board. Inappropriate fluid therapy can lead to worsening of congestive heart failure, especially those with low cardiac output heart failure like cardiomyopathy, myocarditis. So don't give a lot of volume. Inappropriate oxygen therapy can lead to worsening left to right shunt, decreased systemic cardiac output, and worsening the heart failure, like case of BSTs, ASTs, PDAs, or PT shunt patient. Up to 87% in an American study published a few years ago, up to 87% of patients came to the ER with heart failure were missed until third visit. So it's very unlikely that you will miss the diagnosis of heart failure because of the similarity to other non-cardiac presentation to the ER. And if you have patient with cardiac failure, this is one of the best algorithm to treat them based on. You assess them clinically, you do your CBC and some electrolyte and enzymes. You can, to confirm diagnosis, consult cardiology. So if they are known, came to you, if you look at the left side, there is the category of warm and wet. So their blood pressure is good, but they have lung congestion. So those type of patients, they mostly need only diuretics. So you give them Lasix without a problem. The other one, if they are warm and dry, these are the good ones. So they don't need Lasix and unlikely to need inotropes except if they become hypotensive. If they are cold, so they have low cardiac output and wet, they have congested lung, this is the worst type of them. So they need diuretics. At the same time, they need supportive therapy to their blood pressure. If they are cold and dry, so their cardiac output is low, but they don't have congestion in the lung. So those type of patients, they don't need Lasix or diuretics. They can get worse actually. They need inotropes. So you have to differentiate between these four categories. And you aim to bring them back to warm and dry category, okay? The ECG in pediatric in general is a difficult topic because it's not a common problem, even for cardiologists. So in ER, you guys usually see the most of these presentation. They can present at any age. Remember that repaired cardiac, congenital cardiac disease is not normal at all. If they have VSD that's closed, their heart is not normal. They can have any arrhythmia at any time of their age. Genetically inherited arrhythmia condition can be expressed at any age. That's why you might have WBW, they present at you at 5 years of age, although it's a genetic disease. Their problem was there from the beginning. Narrow complex tachycardia is the most common. Computer-generated ECG interpretation is dangerous sometimes. It can mislead you. So please don't depend on those interpretation because yes, some of them are good interpreting pediatric patients, but I notice most of the ECG done by nurses or doctor, they don't enter the age, so you have totally different diagnosis by computer-generated report. So look at it by yourself. So the most common is narrow complex tachycardia. If the P wave is there, the heart rate is less than 200, it's most likely sinus tachycardia. Look for a cause of fever, pain, or something like this. If it's variable, it's not cardiac. If it is narrow complex tachycardia more than 200 with no P wave, if the blood pressure is okay, do vasovagal maneuver or adenosine. If convert to sinus, that's it. If did not, call cardiologist. But if they are not stable, they have shock, reduced blood pressure, please, as soon as possible, use synchronized cardioversion and admit to the ICU. Wide complex is very rare. It can be regular, like a VTAC with good blood pressure, and at that time, at that case, you can wait, call cardiologist. If they are in shock, you don't have time to call for help. You use synchronized cardioversion. If it is regular, it can be SVT with aberrancy, where it looks like a VTAC, but it's not a VTAC. It comes from above, but it's a wide complex. you consider adenosine and consult cardiology if they are stable enough to wait. If they are irregular, it could be atrial fibrillation with accessory pathway, and that has to be dealt by a specialized cardiologist. One of the most common cardiac presentation is syncope. You have to take a good history, especially family history, dynamic physical examination, do basic workup like ECG. If the exam is normal, there is no abnormal physical examination, you can dig more in history. If there is no problem, recommend reassurance, fluid management, salt taking. If the symptoms have improved, you can reassure the parent. If not, refer to cardiologist for further workup. Chest pain is also one of the not common but not unusual presentation. If it is localized and sharp, present at rest, that's reassuring. If it's diffuse, substernal and squeezing type of pain, that's as alarming signs and symptoms. Most of the sharp localized at rest pain is chondro or costochondritis related or muscle or bone pain. So you just need to reassure the patient or the family. If it is diffused, substernal and come with exercise, you have to do some basic investigation, at least ECG and troponin. If there is any problem, you have to call the cardiology urgently. I cannot leave without insisting on point of care ultrasound in the emergency department. And I know for more than 10 years now, it is required fellowship training part, at least since 2010 in the North American training and in other parts of the world. The focus examination is recommended as a core application. It is necessary to apply to assist symptomatic patient, to identify the pericardial effusion, identify cardiac standstill in case of cardiac arrest, evaluate the function, and assess the volume status of the inferior vena cava to help you, to guide you to manage the volume status of the patient. It's not difficult to learn. I know you guys in the ER is mastering this more and more with time. In fact, ultrasound become necessary in many critical area of medicine, like anesthesia, ICUs, and emergency. If you are working in these three areas and you don't know how to use ultrasound to assess the basic function, anatomy, bleeding, effusion, you have to work hard to get them. It's not difficult. 4 areas that you have to put the probe on parasternal, subcostal, and apical. Easily you can get familiarized yourself with the shape of the heart, the function of the heart, and what's around and inside the heart. For example, very easy to look into this heart and tell that there is a black shadow outside the heart, which is significant pericardial effusion, and you can call for help, or if the patient in hypovolemia or hypotension status, you have to drain this pericardial effusion. Few slides about chest X-ray in the ER. As we all know, the X-ray has its significant shortcomings in terms of sensitivity and specificity. It's neither having good sensitivity nor good specificity, though it's slightly better than sensitivity. You don't always have this clear cardiac cause of abnormal X-ray with big heart and congested lung. To be able to label him as a cardiomegaly with congested lung, you have to do a lateral X-ray, because AB alone is not enough. You might have a heart that's big in the AB but small in the lateral. And this is how we use it. We draw an imaginary line, which is anterior tracheal line. And you can see this line on the lateral image of the X-ray. If it is intersect with the spine above the diaphragm, that means there is a cardiomegaly. If it did not intersect with the spine above the diaphragm, just below the diaphragm, unlikely to be cardiomegaly. And I'll show you an example of this. For example, this is a heart that's big in the AP on the right side, but it's small on the lateral X-ray, because that line that we talked about, the anterior tracheal line, did not intersect with the spine above the diaphragm. The heart is small in the lateral, but it's big in the AB because this is just a thymus shadow. While this heart, as you can see, is big on the right side in the AP view, but it's also big on the left side lateral X-ray, because that line intersects with the spine above the diaphragm. This is a true cardiomegaly. This heart is big in both axes. And it's not always the heart itself that's big. It could be just the fluid, as we talked about. This patient has pericardial effusion that has need to be drained. But not all big heart in the X-ray is cardiac. This patient has a huge, we call it wall-to-wall heart. And when after investigation, it was clear that this patient tend to have big mediastinal tumor. But the small heart is good to reassure you that there is no problem with cardiac size. However, it still can be a cardiac lesion like this one, tetralogy of Fallot with a boot-shaped heart without cardiomegaly, without congestion of the lung. So neither normal nor abnormal X-ray can be very helpful to roll in or roll out until you do all the other investigation. Don't forget that there are rare causes of cardiac problem that can present to the ER. For example, this is a baby who 5 months old presented with recurrent cough. And when you do the X-ray, if you look at the upper left, you can see the indentation on the left side by outside structure. If you look at the right upper X-ray, you can see the same indentation from the back. And when you do an X-ray, you can see that with barium study, it's clear that this patient is having a vascular ring compressing the esophagus from behind, causing recurrent cough and aspiration. I think that's it. Thank you very much for staying late.
Thank you, Dr. Abdullah. Can you just join me, Dr. Ahlam? I will try to read some questions online. So as in Zoom, no more new questions. Just I will try to read all of them from the previous lectures. So I would like to thank Dr. Ilham and Dr. Abdullah for them lectures. And just we would like to you even for your attendance. Dr. Muhammad Al-Fayfi, he's busy now. He cannot be closing this sessions. So any questions for us, you can send it to our email or to our website, and we will answer it as soon as possible. We hope you enjoy our the 7th conference in pediatric, and we hope that there is an 8th until we reach 70th, inshallah. Any questions, just send it to our email or website, and we hope that you will enjoy again. Thank you so much.
Thank you.
لا